heavy on the morning as a first one.
Okay.
Okay. So again, we'll just of course start with the instrumentation already set up for laparoscopic surgery. This will be a quick one, so it wouldn't be so dragging in the morning. So I'll be discussing about the setup for basic laparoscopic surgery, the system we use, the instruments and the monitors, other associated and special instruments, and of course the most common laparoscopic instruments that we use. Okay, so our instruments have different purposes. The first instruments that I'll be introducing to all you guys, or reintroducing to all of you guys, is the instruments that will visualize the surgical field. So here's an example of an endolaparoscopic OT setup. So we have our tower, the diathermy machine, smoke evacuator, of course the bed with our patients, the laparoscopic instruments, and I'll be going one by one. So we'll start with the laparoscopic stack, or what we call our lab tower. So the motherboard, or what we call our processor or module, this is the controller unit, and it captures and processes the video signals taken by the telescope and the camera head, and it brings it up to the video monitor so we can see what we're doing during our operations. So there are several functions in this module. This is where the fiber optic light on and off. This is where we adjust our light, our white balance. And this is the brightness. And here is where we use our special functions. So sometimes we use ICG and yellow enhancement and some infrared as well. This is where we connect it to the camera using the fiber optic camera machine also. Okay, next is what we have, our video monitors. Most of the time we have two, one for the view of the surgeon and one for the view of the assistant. So now we already have HD video cameras. Usually it should be the same resolution as the camera head and the same with the processor enclosure as well. So here is the camera head. So this is where we connect the telescope, and this is what connects to the processor and the module. So here we have the ocular coupler. This is where we connect the telescope. The focusing dial is where we focus our images to make it more clearer. And the optical zoom is on top. There's also fine adjustments of the focus also there in that area. And in some institutions, I guess, I haven't seen one myself, but they have this 3D monitor. The 3D cameras have been developed to address the depth perception in some cases. So in this image, we have a monitor, a processor, and a camera head, all fit for 3D camera. So the surgeons, the nurses, and the assistants should also wear a 3D glasses to be able to appreciate the 3D image. Sometimes they use this for hepatobiliary surgeries or gastric surgeries as well. So here's the telescope. We have two parts, the eyepiece, which we connect to the camera head, and the light post where we connect the optic cable. So there are different types of this camera. The newest ones has a much brighter and better transmission. Better transmission, and it's sharper. The field of view is also wider, and it's more slimmer and more durable. So we have several types. We have the 0 degrees, which usually the gyne uses, or we use this when we do optical entry. So it's flat at the end. There's no angulation. The 30 degrees, we have an angulation here. So it helps us more with seeing different angles during our surgery. So also use this for laparoscopic colposcopy as well. And we have also two types in terms of the size. We have a 10mm one and a 5mm one. Okay. So here's just an example of how you would see images through the different types of telescopes. So for 0 degree, you'll see it like a flat image, how it is. In a 30 degree, you'll see it in an angle. So for the 30-degree, to be able to use it properly, you should be able to move the light stick. So when you move the light stick on the right, you will see the left. It's the same with the opposite side. So when you move the light stick to the left, you will see the right side. So this is what we use for laparoscopic cholecystectomy, like to see the posterior and the anterior side. And sometimes in ventral hernias, when we want to see the anterior side as well. Okay, next on the lap tower is our lap light source. So this is where the light bulb, the heat filter, the condensing lens are usually processed. So the most common lighting we use now is the xenon bulb. Because the previous ones used quartz, halogen bulbs, and incandescent bulbs, and they had problems before with the light. So what we connect to the light source, of course, are fiber optic light cable. This cable is, the principle is based on the total internal reflection of the light. So the light would enter in one end of the scope and then would transmit all the way through the telescope. There's another type of light cable, which is what we call the liquid crystal gel cable. So this cable contains, of course, clear gel, and they said that it transmits a complete spectrum of light. So light is more brighter using this one. So usually this is used for ICG. Okay, so of course we also have to know how to take care of the light cable. We're the ones using it during the operation. So avoid squeezing, stretching, and sharply bending the cable. And make sure when you grasp the connector piece, you insert it as one piece, so it doesn't break at that end. Also, you avoid puncturing it during setting it up with a towel clip. Do not turn on the light source as well before connecting the light cable to the telescope, because sometimes it can burn the instruments and the drapes. Also, sometimes the patient, if you leave it open for too long. And always wipe the cable gently, especially the optic light one, because it breaks easily. It's a little more fragile compared to the traditional fiber optic cable. Okay, now we go to the insufflator. So the insufflator has several functions as well. Of course, it's what's gonna insufflate the operative field. So here we have the pressure. The usual pressure we use during the operation is around 12 to 15. This is the pressure that opens up the abdominal wall here. So the flow rate is the flow at which the air is coming into the abdomen. So usually we use low flow for initial insufflation and to avoid gas embolism and barotrauma to the patient. So we start slow first, and then we increase to either medium flow, because this is what we usually use during laparoscopic surgery. High flow we usually use when we're doing suctioning, because of course suctioning will be bringing out some air, so we have to put a little high flow. Or for obese patients, because the adiposity is a little heavy. So we need a little more flow rate just to increase our field of vision during operation. So of course these has effects on the body, right? So if we increase the pressure and increase the flow rate, usually the abdominal wall will go outwards, and the diaphragm also will go upwards. So this will increase the intra-abdominal pressure and reduce the thoracic volume. So what are the effects of this? So if we do increase the intra-abdominal pressure, there will be decreased respiratory compliance. The patient will have hypoxemia. And usually what our anesthetists do, that we don't usually recognize, is to increase the ventilatory rate. Also, it can compress the vascular organs we have there, usually the aorta and the portal veins and the portal veins. So we increase the venous return, increasing the arterial pressure and the MAP eventually, and we will see this as like bradycardia for the patient or high BP. So we just, the anesthesia will always tell us that the patient is having too much pressure, so we just dissipate a little bit or lower the pressure. Okay. So also in the suppletor, we have our CO2 flow indicator. It indicates the total volume CO2 already used during the operation. And some machines have a smoke evacuator built in. So it suctions out the smoke, so we don't have injury to the surgeons and to the nurses during the operation. So there's one that's also not part of the machine. This is an external device for smoke evacuation as well. Usually this connects to a tube and we connect it to the tube parts. Okay. So CO2 is an ideal, they call an ideal insulating gas because it is colorless, non-flammable, non-toxic, highly soluble to blood compared to air. And once it's absorbed, it's dissolved in the blood and delivered to the lungs for excretion by ventilation. So if we have too much of CO2, so there will be myocardial depression, vasodilation, catecholamine release, and will cite a lot of things to the patient. Also, sometimes blunts the immune response to tissue injury. So here is just an extra machine. We have a diathermy machine. This has two functions, a monopolar and a bipolar. So we just connect an instrument there. And we have a foot pedal here also for the surgeon to activate. Okay, so we're going to the next set of instruments. The instruments we need to create and maintain the domain or the space where we're working. So these are the trocars. So the trocars is what we use to gain entry into the workspace. It's also where we connect our CO2 insulation here in this port. It also maintains a pressurized workspace, and it's also a conduit for instruments to pass through. So this is where we put all our instruments. So there are several trocars. The Veress needle is used for a closed technique of obtaining pressure to the abdomen. And we have the open technique here, the Hasson trocars. So we have a reusable one, a metal one, and the single-use ones here. This one has a balloon port here, and this one is just what we screw to the seat also. Okay. And we also have what we call an optical trocar. So this is the usual trocar. It has a hole on top where we put the camera in. Usually we use this for obese patients. So we can know, or we can see it's a safe entry going in. Or with patients with multiple abdominal surgeries also, so we would know that we're not injuring any bones. Okay. Also, the working trocars, we have two types as well, the single-use ones here and the reusable ones. So we also have ones with blunt tip and ones with blade. Usually we put this under vision after we put the camera down. And we also have what we call single incision laparoscopic surgery. So this is just one port. Usually it's by the umbilicus, right? We have a different instrument to use with this because the angulation is very difficult because we're entering through one. So usually these instruments are thin and they're bent in a certain way. So you'll be able to operate properly. Okay, these are other special trocars. This balloon dissector we usually use for hernia repair. This one, when we insert this, there will be a deflated balloon and we put the camera here. So it's like an optical port, similarly. So once we put the camera in, we will visualize under vision the insufflation to see the space opening up. Once it opens up, we remove this portion and then we'll be able to use this trocar for operating as well. And we also have what we call a hand-assisted lap disc. This is when you don't want to exteriorize anything, but you need your hands to dissect inside. So it's like a wound protector, but your hands can go in and do the dissection. Okay, now we're on to the last set of instruments, the ones we use to perform surgery. So what's the important things to consider when we're using instruments? We have to, of course, consider the shaft diameter. So if we want to use 5mm or 10mm, usually with pediatric patients we use 5mm instruments. The length as well. So there are longer ones for these patients because we have a lot of adiposity to go through, so we can operate more comfortably. And pediatric patients which are much shorter and smaller. And the jaw, ones that are straight, hooked, curved to facilitate dissection. Articulation, this is when they're atraumatic for the bowels or more delicate organs, and the serrated ones, which needs more grabbing. Tip rotation, I'll show later, and the handle design. So we have the ratcheted ones and the ones that we can use. Okay, so here is the tip. This is usually the one that is different with all the instruments. This tubing, this is what goes inside the trocar, and it's insulated. So if we have a hot instrument or instruments that we use electrocautery, this side won't burn any tissues. Only the tip would burn the tissues. The rotator is what we use to rotate, so it acts like our wrist in a way. And the handle. There are two types of handles. This one is the free handle, and this one's the ratcheted one, so we don't have to keep the grip in there, so it's more comfortable for the surgery. Okay, so we have two types, reusable ones and the single use. Single use is just one piece instrument, and the reusable ones are assembled ones. So this is the different ones that I showed you a while ago. So this is the tip that changes. Okay, so we'll go through all the instruments very quick. These are atraumatic graspers, or the ones without teeth. So it's safe to use for the delicate organs, which are the stomach, the intestines, some lymph nodes. This is other ones, the bob cup we use for appendectomy, and this one for the bowels. And we have the ones that grasps, or the toothed ones. So this is what we use like to extract specimens, or sometimes we use this for the fourth port in cholecystectomy as well, so we don't move so much. Same here. And these are the dissection forceps. So these forceps are like our mosquito and our right angle instruments that we use for open. So we have a Maryland forceps here. This one's angled in a way. And we have a straight one as well, and a 90-degree one. So this is what we use for cholecystectomy as well. We have the scissors, we have a curved one and a straight one. And bipolar instruments, for the instruments with a little hook here, so we can connect to our electrocautery machines. And we have the needle holders. Actually, the needle holders have different handles, whichever is more comfortable with you. So there are different types as well. And these are our special instruments already. So we have suction and irrigation. We have suctions that are open all the way and open only by the side. These ones we use usually next to the intestines, so we don't injure them so much. And this one has a button here, a trigger. So there's one for suction and one for irrigation. Also the hook, this is what we use for fine dissection as well. So there's different types, the J1, the L, and the spool. And our retractors. So the Nathanson retractor, the snake retractor, usually we use this to retract the liver. It's not the fan retractor, but the fan you can also use for some bowels. So it opens up just to retract. Okay, the clip applicators. So clip is what we use as an alternative to tying vessels. We have different sizes as well. The different size would correspond to a different size of the clip applicator as well. So this one is a 10mm one. The small one can fit into a 5mm. Retrieval pouch. This is where we put our specimens at the end of the procedure before we end. Tissue approximations. We have an endoloop. This is what we use to tie intercorporeally, this one. We can use this for cholecystectomy and appendectomy, or anything that we have to tie. Knot pusher is when we tie from outside, then we push the knot inside, hence the name. And staplers. This is what we use for bariatric surgery, for colorectal surgery. There are some now with angles, so it would be easier to stapler at the angle. And there's also different sizes. We can use this also for vessels. I think the white ones is what we use. We have also manual ones, and we have electronic ones as well. And the suture passer. Suture passer, this is what we use for ventral surgery when we do transfascial suturing. And other special instruments like the biopsy forceps. I think we have one similar when we use sigmoidoscopy. And cholangiocatheter. This is what holds the cholangiocatheter during intraoperative cholangiogram. and a multifunction one. This one has electrocautery, suction, and irrigation already. And then it has a switch here. That's where you switch all the three functions. And the fixation device. This is what we usually use for hernia repairs. So we have different types of fixation. We have the plastic screw ones, or the clips, the metal ones, and glue. Okay, we're almost done, huh? So for the OT setup, of course, we have to talk about ergonomics. So there's a principle that we have to follow. The surgeon, the field of concern for the operation, and the camera, I mean the video monitor, should be at one straight line. This is to enhance the operation for the patient as well and for maximum efficiency. We also make sure that there's proper triangulation so we don't clash the instruments during the operation. It's also more comfortable for the patient and for the surgeon to operate. So these are examples of the triangulation and the straight line principles. You always make sure that you're facing your target organ. So here, this is a laparoscopic cholecystectomy. This is the straight line that we're talking about. So usually your instruments, camera would be here, and the instruments would be at these angles. Same with appendectomy. There are two approaches to put the boards in appendectomy. And here we have what we call a manipulation angle. So the manipulation angle is where the instruments will not clash. Usually it's around 50 to 80 degrees. And the azimuth angle is just half of the manipulation angle. It is where the comfortable angle where the instrument will not clash with the camera. It's usually more productive with 30 to 45 degrees. So here, the positioning. The ideal position for laparoscopic surgeon is a relaxed stance with the arms slightly abducted, retroverted, and rotated inward at the shoulder level with the elbow bent 90 to 120 degrees angle and the neck slightly flexed with a downward gaze. So ideally speaking, the monitor should be 90 to 20 centimeters away in a straight line across from the surgeon. And the surgeon should have a slightly down gaze view because it's more comfortable. The screen should be positioned a little lower, so the surgeon's eye level to avoid the neck extension and the strain. And the most comfortable viewing direction is approximately 15 degrees below the eye level. And as you see, the instruments are like a little lower the waistline as well. Also make sure that the stepping, like we have to practice the diathermy, the step boards, they usually put it here also. So we don't twist our ankles when we're operating. So here's an example of positioning. Usually the surgeon positions opposite of the target field. So when you're doing laparoscopic cholecystectomy at the right upper quadrant, your surgeon will be on the left. The cameraman is usually on the same side of the surgeon, and the assistant is opposite the surgeon. So here's another example for appendectomy. So since the target field is here, your surgeon is here, cameraman next to the surgeon as well. And for hernia repair, for doing the right hernia, surgeon on the left, cameraman next to the surgeon. And ventral hernia repair. This one will depend on where your hernia is more directed towards to. So if your hernia is more on the right side, it's more open to, right? There's more space to work with if you're on the right side, the opposite side as well. So just a little touch on robotic surgery since it's been with us already for quite some time, but there's only like 24 robotic devices that's been available in the market. So they said that there's more precision and dexterity with the robot. It's still minimally invasive, but it has the same advantage with laparoscopic, which is smaller incisions, less blood loss, and faster recovery. And there's enhanced visualization with the robot because there's 3D and HD imaging. Also, the ergonomics is improved with the robotic, so there's less surgeon fatigue. And I haven't seen this, but there is already AI integration in the robot. So you're able to teach the surgeon the navigation and to help with the decision making. by identifying the structures during the operation. But again, there are limitations. So it's still high cost. It's hard to acquire to some institutions. There's also problems with accessibility, limited availability also. The learning curve, I think they're still working on this, but some say it's a little easier compared to laparoscopic. And there's an evidence gap because since it's new, there's still a lot of research that has to be done. But there are some procedures already that's proven that robotic is much better than laparoscopic surgery, such as prostatectomies and other gynae procedures with pelvis. So, to conclude this lecture, we have to, aside from the instruments, we also have to know ergonomics, which is very important, so we can be more comfortable and less fatigue and injuries to us as surgeons. We also have to consider, which I wasn't able to include already, the patient positioning. This will help the patient post-op as well with the recovery, and so there won't be any injuries to the patient other than doing the surgery. And the proper use of equipment, so there will be longer use and they won't break through. Okay, that's all. Thank you.
Thank you, Dr. Dor. You told us about the instruments and the setup. So without further ado, I'm going to introduce our next speaker, Dr. Loh Hau Kiao. He comes from Ipoh, Malaysia. He works at the Hospital Raja Permaisuri, Bainun. He's a general surgeon by training, with a special interest in hernia surgery, acute care, and a bit of peripheral vascular work. So Dr. Loh, please.
Thank you, Dr. Sean, for your kind introduction. Thank you, Prof. Lamanzo, I think he's not around, Sujit, as well as Sean for inviting me for to help out for this workshop. Thank you, Olympus, as well. So today, I'm going to talk about suturing and stapling. So right, this is hospital by Ipoh, alright, so I work. So next, all images and reference here, instrument brands presented in this lecture are purely for educational purposes. Doesn't carry any advertising or promotional intent. So today, this is the outline of the topic. Basically, we're going to talk about sutures, staplers, and basic properties, followed by the selections, then the steps for it. So let's talk about suture and properties first. Sutures are medical threads used to hold body tissue together to establish a functional continuous tissue and bone, and also to produce an aesthetical scar. So things to consider during the suture selection. This is the suture. First, you need to consider about needle point, followed by the needle shape. Lastly, is about the suture material and also the diameter. Needle point. So there's a lot of needle point that we everyday use of, but then these are the four usual needle point that we usually use, which is the first one, the tickle point, which is usually used to dilate rather than to cut. All right, or this one we usually state the round body. Next is the reverse cutting. We usually use to suture the skin, and also this conventional cutting as well. Lastly is this taper cutting, which usually we use it for suture vessels, okay, cardiac and vascular procedures. Needle shape. There are lots of needle shapes from 1/4, 3/8, half circle, and J shape, and also straight needle. But then this is the usual one that we use for laparoscopic suturing, the half circle. Next, the suture material. Suture material we can broadly divide into a structure, behavioral, or origin. Structure can be braided or monofilament. Behavior can be absorbable, not absorbable. Origin can be either natural or synthetic. So every time when we consider how to choose the suture, usually from our mind, we think of whether we want to use the absorbable or non-absorbable first, followed by whether you're going to use the braided or monofilaments. These are all the examples for all the different types of sutures that we are used daily. And among all of these, these two catgut and also silk are the examples of the natural sutures. Suture diameters. Most important thing, first thing that you need to know is USP. USP is essentially United States pharmacopoeia, where it's a system use numbers and zeros to determine the suture diameter. So basically, 10O, the diameter will be 0.02 only the diameter, where the USP size 2 is equivalent to 0.5 mm in diameter. So for this 6O until 10O, usually we use in ophthalmic surgery or microsurgery, followed by this from 2O to 7O, usually we use in plastic surgery or critical surgery. For our general surgery and ONG, usually we use suture size from 2 to 4O. So next, a new piece on the block, which is the barb suture, which is loved by all the laparoscopic surgeons, because it's a specialized knotless surgical tract designed by with tiny projections along the surface that anchor into the tissue and eliminate the need for traditional knot tying. And how we get the idea is inspired by the structure of these porcupine quills. However, for barb suture, the advantages using it is reduce the operative time, improve efficiency, and also better cosmesis. However, there are limitations as well, which is it's very costly and it's also have a slightly reduced in the tensile strength. So let's go on with the laparoscopic suturing. So from the side, these are the steps for the laparoscopic suturing. Let's go on one by one, step by step, how we're going to do it. So first of all, instrument selection. You need to select appropriate instrument to do your laparoscopic suturing. You might need a laparoscopic needle holder, Maryland, or bowel grasper. Port size, you might use a size 5, 10, 12, or 15. Depends on situation. Next is port placement. A very good port placement is very important because good triangulation will give you the optimal suturing. There are a few ways how we're going to place the port. First is by doing a contralateral port placement, where let me guide you through. This is the midline, this is the telescope, and then this is called the contralateral port placement. All right. So one is on the left, the other one on the right. Next, we can also do ipsilateral port placement for laparoscopic suturing. This is a midline, this is a telescope, and then this is where your port, your instrument going to be put. Next is a midline port placement, where one of the instrument port will go through the midline. Let's go through. This is a midline, this is a telescope, and you can see one of the instrument is being put through the midline. So don't forget about the ergonomics as well. And next, after deciding regarding for port placement, next is about suture selection. So it's again go back to our choices of suture, whether braided, non-braided sutures, and also whether you're going to use the absorbable or non-absorbable suture. And then you also need to decide about suture length. So for intracorporeal suturing, usually you keep your suture length around 10 to 15 centimeter. Whereas if you're going to do extracorporeal suturing and knotting, then you might need the whole length of the suture line. Next, before we go into starting to put in the needles inside, there are a few points in the needle that you need to know. I mean, important points for handling needle. Point A, which is 2 centimeters from the sweat. Point B and C, you basically divide the needle into 1/3 of it. So point A and point B is actually the place for grasping point for during handling. Point C is the place where you use your needle holder to hold your suture during you are doing the suturing. Next, let's go on to the needle entrance.
First, grasp the suture at point A, about 2 centimeters from the needle hub. Then, if you're working with a 10-12 port, you can directly insert the CT1 needle into the abdomen. When working with a 5mm port, you won't be able to directly insert the CT1 needle into the abdomen. You will need to first insert the instrument through the trocar, then grasp the suture and guide the needle into the abdomen. This is called backloading the needle.
the next one, which
First, grasp the suture at point A, about Once the needle is within the box trainer, maintain the right grasper at point A and loosely grasp the needle with your left instrument at point B. While stabilizing your left instrument, with your right instrument gently move in a to and fro manner to swivel the needle. With practice, you will be able to move the needle in every direction freely. Swivel the needle such that the light evenly reflects off point C. Then, using the needle driver, grasp the needle firmly at point C. Release the needle from your left instrument and do a couple practice throws to ensure the needle was loaded approximately 90 degrees to the driver. Once the needle is within the box, Once your needle is loaded, pronate your needle driving hand such that you enter the tissue at a 70-degree angle. Use the curve of the needle in addition to countertraction by your other instrument to guide you through the tissue.
So after you throw the stitch, next thing will be
Once your needle is loaded,
making a knot. All right. So for knotting, you can do either intracorporeal or extracorporeal. For intracorporeal, there are two methods the common methods that we do it, which is the Rosser method and the Sasmo method. Rosser method, in general, actually, basically is how we do it in open surgeries, where you use one side to just do the throws, and then you just pull it through. Whereas for the Sasmo method, you will be actually throwing around your sutures, exchanging around to make your loops before you pull in and knotting the sutures. Let me show you a video. How are you going to do it? Start off with the Rosser method first.
We put the needle back over the knot. We'll swing the swedge in to create a 45-degree angle between the long axis of the needle driver and the needle itself. This will place the right needle driver roughly parallel to the needle itself. Now the tag is on the right. This is the location of the knot that is to be tied. So the needle will be to the left of the knot when the tag is to the right. We start at the 12 o'clock position over the curve of the needle, and we will make 2 clockwise rotations around the needle, grasping the very end of the tag. The left hand then rotates immediately and moves to the 1 o'clock position, while the right hand moves up slightly and then back adjacent to the knot to allow us to have a very short tag. We take all of the tension out with the left hand. We then can release the tag, come back over the knot. The tag is now to the left of the knot at the 7 o'clock position. The needle will now be just to the right of the knot. We'll do a counterclockwise rotation around the needle to grasp the tag. The left hand then goes to 11 o'clock, while the right hand goes to 5 o'clock. Release the tag, bring the needle back. The tag is now to the right of the knot. The needle is to the left. We'll make a clockwise rotation, grasp the tag, rotate our hand immediately 90 degrees, move the right hand to 7 o'clock, and we've completed the knot.
Actually, the Rosser method. So next one, we're going to see the Sasmo method.
We now have the needle to the right of the right-hand needle driver. The suture is coming back at us. The left-hand needle driver is on top of the suture. We rotate the right hand externally. That creates a camel hump. We go over the right-hand needle driver. Do it once more. Grasp the tag and pull it tight. We now change. The left hand grasps the suture. The needle is to the left of the left-hand needle driver. The right hand is on top of the suture. We rotate externally, and the needle driver goes over the left-hand needle driver, and we pull that down. We then grasp the suture with the right hand. The needle is to the right of the right-hand needle driver. The suture is coursing back at us. The needle is on top of the suture. We rotate our right hand laterally to create a camel's hump. Left hand goes over the right-hand needle driver, grasp the tag, and pull it tight. We now have the needle.
Next, we proceed on with doing an extra corporeal suturing.
We now
Another
have
video to show you how to do extra corporeal knot tying.
And now, let's move on to actually tying the knot. We'll do our first throw. So the important thing here is the Y. And the reason the Y is important is we can loosen tension on one side or on the other, depending on how the knot is running. Rest the knot pusher on your thumb, and that allows it to be steadier. So then you're going to push past your knot, and when we advance the knot, what we want is to push to the side of the knot, and we can see that that will slide. If we try and push right on the knot, then we see that the knot won't slide. So again, push to the side of the knot versus pushing on the knot. And in one fluid motion, you're going to advance that down. When you cinch the knot down on the inside, you continue to push to the side of the knot rather than right on the knot. And then as you remove the knot pusher, it's very important to maintain tension on the suture until you've tied the next throw and you've secured that knot, just like you would do if you were doing an open tie. And generally speaking, you're going to tie 3 knots, again, just as you would do if you were doing an open tie.
Do an extra corporeal knotting. So before I move on to the next one, so I want to emphasize here is about laparoscopic envelopes. It's a very useful loops that we use to tie up all these small to medium tubular structures without needing you to do any suturing. These are the pre-mixed one, but however, for most of the time, when let's say you are in districts or anywhere that you don't have all these things, then you need to learn how to do it. We do it the broadest knot, alright? So basically, it's a 1-3-1. So beside that, I put a diagram for you all to see. And now you just see through just within 1 minute. To do gastrectomies, okay? And use it to do pancreatectomies or lobectomies, as well as to connect the two bowel together. So what are the types of surgical staplers? Basically, you can divide into open surgeries and for laparoscopy. For open surgery, it can be a linear or circular, and for this laparoscopy, usually it's a linear one. So let's go through very fast one by one. These are all called the linear cutters. You have to see that actually the staplers and the axis of the cutter is actually in the same axis. And then this kind of stapler usually you can staple and cut. Whereas for this one, it's called a linear stapler as well. But then the stapler is the stapler line is perpendicular with the axis. It usually depends on how and where you want to put in the staplers to do. Sometimes you might need just now the previous linear one, and probably sometimes you might need this perpendicular one. However, you must know that this one usually you can staple, but you cannot cut. You need to cut it manually. Next, these are the curved stapler where you use it in your narrow cavity, such as your pelvis. Okay, this stapler can be used to cut and staple as well. Now, next is this is a circular stapler where you use use it to connect between two hollow organs. Usually, you use it during your esophageectomies, or you can also use it for your anterior resections. It can be used to staple and cut as well. And then this is a stapler that designed for laparoscopy surgery. We call it the endostaplers, where the head of the staplers there is actually adjustable, and it can be used to cut and staple as well. And to make things more even better, they now develop this battery powered stapler already to improve the stability for firing the staplers. Next, staple bullets. The small thing there is staple bullet. It is an unfired bullet. This is staple wide and the open staple height. If it's stapled, it should be a V shape. And the V shape is important. To configuration of the V shape is important to make sure that the tissue is held together properly. And for all the V shape, it's not all the V shape will be accepted. There are accepted V shapes and not accepted V shapes that we need to know. Next is about stapler selection. Different color you will see a lot of different colors. Okay, different color means different bullet height. Okay, but in the same time, different bullet height meaning that is meant for different tissue thickness, right? So whenever you choose a stapler, you must, number one, consider the stapler height. Number two, how long you want the stapler to be. And from here, you choose the color and decide from there. Gray one is usually for vascular, meaning it's very, very small, all right? And then for the white one, it's usually used for thin tissue, okay, such as a big bowel. For blue one, you usually use for regular tissue, for small bowel and for lung. For the green one, you use it for thick tissues such as the rectum, large bowel, and stomach. And black one is usually for extra thick tissue for stomach and also pancreas. Bear in mind, because those stapler in green and black is quite thick, so you need to put it in the 15 mm box, where the rest you can put in the 12 mm box. Sometimes you see purple and gold stapler as well. Where are they in this list? Actually, for the gold one, it's actually replacing this blue and also the white one. And then for the purple one, it's actually replacing for this green and blue one. Why is different color? Because it's from different company. All right. So let's go on to the principle of stapling. Hopefully, I can play the video. Hopefully.
Check the return lever is pulled back fully prior to connecting the reloading unit to the universal handle. Securely lock the reloading unit firmly into the pin located at the end of the shaft by aligning the load indicators and twisting 45 degrees anti-clockwise. Remove the shipping wedge from the reloading unit. Do not attempt to remove the shipping wedge until the reloading unit is locked into the universal handle. To check the reloading unit is successfully loaded within the universal handle, squeeze the firing handle once to close the jaws of the device and pull back the return lever to fully reopen. Once you have confirmed the reloading unit has been successfully loaded within the universal handle, squeeze the firing handle for a second time to close the jaws of the reloading unit and pass it through the trocar cannula. Ensure the anvil of the reloading unit has fully entered the body cavity and passed through the trocar cannula before pulling back on the return lever and opening the jaws. Using the 360-degree rotational wheel, position the tissue to be stapled between the jaws of the reloading unit. Articulating reloading units allow for further maneuverability when the articulating lever is turned from left to right. Only tissue positioned within the cut mark lines will be transected. Additional reloading units may be required for tissue exceeding the length of the cut mark lines. Close the jaws of the reloading unit across the tissue to be transected by squeezing the firing handle. The jaws of the device may be repositioned on the tissue prior to firing by fully pulling back on the return lever, allowing the jaws to reopen. Once the correct positioning of the tissue to be transected has been established, allow 5 to 10 seconds for tissue compression. Press the green safety interlock button. The device will not fire staples and cut tissue unless the green safety interlock button is pressed. Fire the device by repeatedly squeezing the firing handle. The number of squeezes to fully fire the device is relative to the length of the reloading unit. Once the device has been fired, pull back on the return lever to open the jaws of the reloading unit and gently remove the device away from the transected tissue. Inspect the staple line for hemostasis. Close the jaws of the reloading unit by squeezing the firing handle and remove the device from the trocar cannula. Check the return lever is pulled back fully prior to connecting the reloading unit to the universal handle.
So understanding the basics and principles for laparoscopic suturing and stapling is important to perform the procedure properly. However, the key of success of doing it is by continuous practice it and also self-reflection on each procedure. Okay, all right, thank you very much.
Dr. Rose, basic principles on suturing and stapling, which is very important for all of us. Okay, next up we have Dr. Long Xiao Hao. He's a hepatobiliary surgeon here at the National University Hospital and also at Alexandra Hospital. So he'll be presenting for us on safe cholecystectomy, the critical view of safety. Dr. Long.
Thanks, Sean. Yeah, I'll keep this brief. I'll try to go through things that you won't be able to find in textbooks or the standard online resources. So these are the published success metrics in literature. But obviously our aim is to be better than this. And mortality should not exist. Same day or 23-hour stay should obviously be strived to be 100%. But we will always not be able to predict which are the ones. Bowel injury is the main focus of this talk. And there are two essential types of bowel injuries. One is vascular, the other one is the bowel duct itself. So let's see what are the strategies we can employ. Okay. With regards to anatomy, I'm sure all of you know that there are varying insertion of the cystic. But there is no need for us to memorize or remember all the aberrant anatomies, because that is not practical and not possible. The whole idea is for us to be aware that there are aberrant anatomies, so that intraoperatively, if anything looks unusual, we need to be more cautious. And that's the context behind knowing the biliary and the cystic artery aberrancies. Okay. So this is standard basic stuff, and I don't think I'll need to go through this in great detail. And again, this critical view of safety is I won't go through this. This is easily found online. Okay, but the main thing I want to go talk about perhaps is the second one, where we separate the gallbladder from the liver bed, the distal one third. The idea is that we want to know where the gallbladder ends, because if you don't know where the gallbladder ends, you don't know where the CVD starts. And a lot of times, I've heard residents don't blindly poke where you cannot visualize. The difficulty lies when obviously the callos is fibrotic or frozen. As long as you know where the gallbladder ends, everything else should be safe. Because the idea is to hug the gallbladder and just stay below it. But if you don't know where the gallbladder ends, any strategy that you employ will unlikely be safe. Okay. So these are some things that we can perhaps employ to reduce bowel injuries. So the first one, the left hand is the most important. 2-port, 3-port gallbladders, regardless. The left hand is the one that guides the visualization. If your left hand doesn't retract properly, nothing is safe. Everything will be crumpled up. Okay. And the second thing is what I mentioned, half the gallbladder is key. Entering the gallbladder is fine. At most you have thousands of stones that spill out that you take 1 hour to clear. But you rather go into the gallbladder than go into the bowel. The whole idea is when we do the posterior window, find the space between the end of the gallbladder and the anterior wall of the bowel. Okay. And the third thing, cautious use of the hook. The heel of the hook, I always tell residents, is not touching any structures. A lot of times the hook goes in and the the heel and the angle of the hook is still touching the back end of something else. So you don't know what it is. So I always emphasize that the hook should be out completely, and the back of the heel is not touching anything else before the burn is done. Blunt dissection, I feel, is key, and I do it a lot of sucker. A lot of us do that. The brushing movement is important, and we usually try to brush up instead of brush down. Downwards is always to a CB, upwards is always safer. And again, the key is not to be blind. That means if you cannot see where is the possible window, don't just blindly poke, especially don't use a Maryland to poke it and just spread when you don't know what it is. Okay. The Rouvier Southern is a good landmark. It's the landmark for the posterior sectoral. Don't go below it. So that's the main takeaway. Don't go below it because aberrance in the posterior sectoral especially is the most common, and you can insert anywhere in the uretry, the left, the cystic, to the distal CBD. And if you go below it, there's significantly higher risk of injuring the posterior sectoral, which is even more difficult to fix than injuring the CBD itself. Any tubular structures we dissect must be traced back to the gallbladder. Anything that enters into the liver should not be clipped, no matter what size it is. Especially our top later is, if anything there's pulsatile and more than 5 millimeters, you cannot assume that it's a cystic artery. Always assume that it is a branch of the right hepatic, posterior, anterior, whichever. And do not flip it until you dissect all the way and trace it and make sure it doesn't go back to the liver. As long as it goes into the gallbladder, it can be clipped. It doesn't matter. Okay. And I put there to beware of sling the CBD. It may sound extreme, but it's not uncommon, especially if the callus is fibrotic and we blunt dissect. Sometimes we go behind the entire CBD and sling it up. Then the mistake happens when we think that there's a stick and we just, in an undilated system, we can actually secure it. That's why I went through a lot, and then we just transact it. And that is danger. So again, if you're not sure, the CBD obviously will enter into the liver. So always trace it proximally until you make sure that it goes to the gallbladder before it's to the deep. So I mentioned about the fine hospital. Fundus first approach, it's something that we always talk about. It's a double-edged sword. It can be employed, but the caveat is if you do not know where the gallbladder ends, it will not help you with improving the safety of the surgery, because if you have no end point, you do fundus first, go down, 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 and if you don't know where it ends, you just go straight to the CBD. So this is only useful if in a frozen callus, that means undissectable, it's rock hard. Then we don't dissect the posterior window at all. We leave a cuff of the gallbladder, the posterior wall, in the patient's body. It's fine. Doesn't matter. So we fundus first all the way down, cut into the gallbladder, that's fine. But we leave a cuff there. It's still a complete cholecystectomy nowadays, because even after you shave it off, you go down, you'll be able to find a lumen of cystic, unless cystic is obliterated. Then obviously there's nothing. But as long as you find a cystic, you'll be able to trace it there. You can even cannulate it and do IOC. But the idea is you want to avoid moving into the CBD, especially when you don't know where the gallbladder is. So just enter the gallbladder from the fundus first, leave a cup on the posterior wall. You can diatomize it later to reduce some mucosal secretions. But once you reach a cystic, if it's a big opening, you can secure it later on with stitching, whatever. But if you can do IOC, that's best. Okay? Adjuncts, IOC is one thing. ICG is something I employ more than IOC nowadays, because IOC may not be possible a lot of times, especially the cystic duct is obliterated in very bad cases. Or if in a wide cystic duct, from IOC is still possible. So you put a bulldog across, you clamp it so that you can secure the catheter and it won't backflow only. or it can. Sometimes the problem is that the cystic tissue is all terrible already because of that infection necrosis. And you won't even be able to purse string and secure the IOC catheter. So a bulldog or even sometimes the third port will just put a grasper, a long grasper, and put a ratchet so that it clamps. And that will be like if you don't have a bulldog clamp, that can act as one. So these are some things. The ICG, it's available, that's best. Intraoperatively, if you decide that you need it, the dose that I give is 0.25 milligrams, very low. Then SAS will keep asking, you sure it's so low, you sure it's so low, because dilution is a lot. They dilute it a lot to give the correct amount. The reason why it's low is because we want to delineate only the biliary system. If you give more, the whole thing is bright and you can't see anything. Best is if the ICG is given preoperatively at a reception, you give 0.25, and then intraoperatively you will nicely show. It's reliable, and even for transplants nowadays, sometimes you don't even do IOC to confirm that thing. So you can just use the ICG itself and just translate the amount of this. So if you give the right dose, it is a good guide. And I don't need to, if I can't form IOC, then this is a good way to see the signal. Subtotal, there is great wisdom in knowing when to stop and failing out. There is no glory in the gallbladder. And if you know when to stop, essentially you can avoid any form of neurovascular injuries. Okay? And converting to open is something that we have at the back of our mind. That's a backup, but it doesn't improve visualization. In fact, if you can't see things well in that, it's very unlikely you'll be able to see better in open. Especially if the patient has a deep cavity, you won't be able to have good exposure of it. So I would say that a subtotal in cases where you're unable to delineate the anatomy well is probably more helpful than converting to open. Yeah. Converting to open is often for us to do a good repair if injury happens. And yeah, safety is the most important. Getting the patient home on time. IOC utility. This slide is just talking about the role of IOC. We don't do it routinely, but we have a low threshold to do it. The main indication, bottom right corner, is we need to diagnose kidney stones. That's the main indication. Yeah, the rest is self-explanatory. IOC, this is so some other things that can happen or problems that we can encounter in the lab fully, a very wide cystic duct in patients with pastole or previous varices, type 1 kind of thing. We're able to dissect it off the CHT. This 15 mm hemolog has saved my life many times. It's a huge hemolog that can go in the 10 mm port. It's bigger than a 10 mm hemolog. So I trust the hemolog much more than I trust the envelope, because in my mind, the idea of the envelope is that it can still slip, but the hemolog can go across and you see the end of the hemolog clip well, it is secure. So if I can, I'll use 15 mm hemolog. I suture only when it's required. If I have to loop it and the hemolog can't go across, very unlikely that the 15 mm hemolog cannot secure the data. If you cannot secure, probably you're in the hard ones. Yeah, stitch only when you truly need it. I use a V-log to do that. CVD stones, if you suspect one, ALP is raised preoperatively, the bill is normal. But you're lazy to do IOC, you can bend the cystic duct. Bending means you just secure the distal end of the cystic duct, like how you do IOC. You just cut a bit and milk it. As long as there's good flow, fine. It usually is unlikely to have a CVD stone. But of course, if you are uncertain, IOC is just an additional tender, it's just get. Fistula. So for fistulas to the small bowel or the colon, the whole idea is to get around the fundus. once you can get around the fundus, generally you will not be a problem anymore. And the trick is to leave a cuff of the gallbladder on the side of the bowels, so that you can firstly, I will usually put an endo loop around distal to the bowel cuff. That's one, but I wouldn't trust it, and I'll overrun it with a suture. And the idea is not to narrow it. So if you have to really, if it's a real fistula where you see anterior contents coming out, you close it transversely always. I'll run it down and up again with the same length of straw fix. Collections, yeah, I always tell the residents to wash until they feel like they can drink it. That's clean enough. And the worst gallbladders are the hot but cold gallbladders. That means it is acutely inflamed, but it's a chronic, recurrent cholecystitis such that the whole callout is frozen. When that's the case, don't need to do anything that's incurable. Just be safe. So takeaways. The junks are there to help you, ICG, IOC, but obviously not a substitute for careful dissection. When you see a bleeding, something spurting, don't reactively diatomize it. It will be terrible. Secure with your left hand, just pinch it very then or what. Suck it nicely and clean it like that before you do anything. Maybe always call someone else. Have a low threshold to call someone else. Yeah. So don't anyhow click and don't anyhow click. That's the main message that we have. And yeah, so don't be too overconfident about yourselves. Things can happen to anyone. Drains have a low threshold, I have a low threshold to place it. Especially in the hot gallbladder. Just place it in. If the patient needs to stay for 1 day, the next day it's clear, just take it out, the patient go home outside. And recognize injuries intraoperatively is just crux. Cause anything that's delayed, interventions are delayed, and outcome is worse. So main thing here is recognize your own limitations. Know the extent of which you are comfortable in doing dissections and difficult ones. Have a low threshold call and help so that there's help bias in the frame. So at the end of the day, it's the patient outcomes matter the most. Their safety matters. Because some of these injuries, once they happen, it changes the patient's lives. That's all.
Thank you, Jiao. Some of the tricks that he shared, reflected from him, I use it on a daily basis. Okay, so next up, we're going to move on to the next lecture. We will invite Young Associate Prof. Sujit. He's the head of the Department of Surgery at Alexandra Hospital, and he practices here in National University Hospital as well. He's a general surgeon by training, with special interest in hernia as well as endocrine surgery.
Thank you, sir. How to do? Yeah. How to do? That was a big idea. So how to do? I don't know. There's plenty of ways to repair a hernia. So open, laparoscopy. How many of you do laparoscopic hernia? Do you know the zones that's described? Okay. And how many of you do open repair? Very good. Okay, so I'm not saying. Yeah. So the current guidelines actually supports a mesh repair. So passing shoulder eyes, we should still understand how to do, especially in cases where there's contaminated field, where you can't do a mesh. You still need to do either a shoulder eyes or a passing. But now there's long-term resolvable measures available, so you can use even in contaminated fields. So yeah, this is still questionable. Yeah, let's move on. So a posterior approach is preferred because if you look at the ergonomics of a hernia repair, when you put the mesh from posterior, it's more ergonomic than putting here. The forces will act this way. So it becomes more ergonomic as well as more physiological repair. If you look at literature, the current guidelines actually supports endolaparoscopic repair even for primary intraabdominal hernia, especially because of the risk of the less risk of SSIs as well as early getting back into the usual lifestyle for these patients. So the anatomy, I don't know how many of you are familiar, but this is a internal. This is a view from inside, be it TAPP or TEP. So you have the Hasselbalch triangle here. Okay, Kathleen, what's Hasselbalch triangle? Yeah, very nice. So that's where your direct hernias occur. Okay. Lateral inferior epigastric is your is the indirect hernia occur. And femoral hernia, this is inguinal, this is lacunar. Okay, so this is where the femoral hernia occur. So when you want to release the neck of a femoral hernia, it's important you protect the vessel, the iliac vein. So you can put your gloved finger and then you can cut this fibrous sheet to release the sac. Some of these definitions may change in the future because we see hernias which is behaving more like direct hernia, appearing lateral to inferior gastric as well, but still we still follow EHS classification. Oh, the other thing, in endolaparoscopic hernia repair, this is also important, obturator. Quadrangle of pain, and so the most important thing is that I'm sure you know the boundaries, but the most important thing I would like to say is in all patients there's a transversalis fascia that is covered. Kathleen, how many layers the transversalis fascia has? Oh, very good. She's one of the very few people in the world who knows that there's 4 layers in transversalis fascia. So one of the layers actually covering all your nerves. So if you disturb this, it's a risk factor for you to get pain. If you do TEP, you do the surgery between the 2 main layers of the transversalis fascia. Okay. And this is triangle of doom. I'm sure you're familiar with that. We are TEP guys because our boss told us TEP, right, Sean? So we we do TEP. So we like to struggle, so we put our poles in the midline. We don't deviate from what Lomacro does, but sometimes we do. Yeah. So let's see how it's done. I think this is a video from 2012. 2013. When Ian and myself we were struggling to learn TEP. Those days we were discussing with each other how to do. Yeah, so the steps are quite different in TEP and TAPP. TEP you start medial, okay? You go medial to lateral. The zone 1, 2, 3 is described mainly for your TAPP.
So TAPP later I will tell you. So zone 1 is your lateral, then zone 3 is medial, then your zone 2 is medial, then zone 3 is your critical dissection of the host fractures. So that's a femoral hernia. That's an obturator hernia. So these are advantages of doing endolaparoscopic hernia repair. So Chris, when you want to use monopolar, so that's how you use instead of bipolar. So that's the layer I was talking about. You see this layer, this moves. So that layer must be there on the nerves. If you take out that layer, then there's a risk of chronic pain because if you put a foam mesh on there, there's some risk of chronic pain. Okay, so TEP, you go from medial to lateral. So space of Bogros is the lateral space. Space of Retius is the space in front of you, which is the medial space. And you go down about 2 centimeters from the pelvic rim. And then the usual dissection should include dissection of all the myopectineal orifices, including obturator, because most of us may not even dissect that low. So you can see quite clearly femoral, and then this is a direct hernia, which is medial. And then on the other side, you saw obturator as well. We don't use ADP2 meshes anymore, but we use flat meshes, or we can use 3D meshes. It's important that your mesh does not go above the peritoneum anywhere, and you hold the mesh in place. And this is a common area where you get recurrences. The mesh falls up, and then the peritoneum sneaks in, and then you get an immediate recurrence. Packing is optional nowadays for small hernia. Maybe for L3s and L3s, you can do some packing. But at the minimum size of the mesh should be at least 10 by 15 centimeters. Okay. Any questions for TEP? We'll go on to TAPP. So TAPP, you mark first. So what are the boundaries? The boundaries is you enter with the subumbilical incision, and then you mark your ASIS. Okay, so the peritoneal marking is at the level of ASIS. Okay, and then your subumbilical incision, then you go parallel, and then you put 2.5 mm. It's good if you can bring the patient's hands down a bit, tug on both sides. Okay, and that makes things easier when you do some suturing and also doing dissection. For TEP also, your dissection limits are ASIS, okay, laterally, and then and when you come down from lateral, your ideal psoas with your transversalis fascia covering it. So these are your boundaries. The same boundaries are there for the dissection for TAPP. The only difference, if you're going to do an ETAP for large inguinal hernia, is you go beyond ASIS, you cut the up, because you do this before you open the peritoneum to reduce your contents. So this is a direct hernia being reduced, and you saw for TAPP, we started laterally. So dissection goes from lateral to medial to TAPP, medial to lateral in TEP. Okay. So in TAPP, you start with the lateral, which is your zone 1, then you go to your zone 2, which is medial, then zone 3, which is dissection of the core structures. The other thing, so this is paralyzation of the peritoneum. So where are the limits of this paralyzation? And there's usually a structure that connects the iliac vessels in the inferior epigastric. This is a fibrous structure. So usually the limit is until you meet this structure, which is like a sling. It slings your vas deferens in males or round ligament in females. Or you feel there's adequate coverage until the mesh can fall back without folding. There's a big direct hernia. So here you can see this is also an exception to the EHS classification. This is inferior epigastric, and you see a huge direct hernia on either side of inferior epigastric. So these are some of the exceptions to EHS. This is handling the transversalis fascia of the direct hernia to reduce the amount of seroma and reduce the chance of recurrence. It's not recommended, but it's a good practice if you can suture the peritoneal flap, because it causes less pain for the patient rather than use factors. So we usually use absorbable without 3. And then it's important that you hold the mesh and then push the peritoneum onto it when you desufflate. Some people can use a sucker to desufflate and then desufflate the abdomen onto it. So that's about it. Okay. So this is our approach that we follow in our hernia center. If it is primary unilateral, well, you have the expertise. You can do endolaparoscopy, but if you don't have the expertise, open hernia with mesh, within sling repair is a good option. Bilateral is an indication for endolaparoscopy because we minimize the amount of surgical trauma for these patients. Recurrence after open, we should do a posterior approach. Recurrence after multiple attempts, you done open, you done anterior repair, even posterior repair. It's good to get a view from inside through a diagnostic laparoscopy. See what has failed and then do a tailored repair. These are some of the things that we have given to the literature in hernia. TP plus originated from us, modified TP originated from us. TP plus already in the guidelines is to reduce seroma and recurrence in a direct hernia. Modified TEP is how to handle distal hernia sac in indirect hernia up to S1. EHS classification has a separate component for invernous-portal hernia. So modified TEP you can use it for endolaparoscopic hernia repair up to S1. Seals not very well practiced. If a patient, especially a young female who's really concerned about the cosmosis, asks to do, I still do it. IPOM is an option when there's multiple recurrences. That's all I've got. Yeah, this is a pathway. That's it. Thank you.
So just learn some of these tricks of EEP plus and FEP too. Okay, so right now I think we'll just take a short break, just about a 15-minute break for a coffee break. We have some refreshments outside, and then we adjourn back here for the brilliant lecture. Okay, so now it's about 10:50. We can come back by about 11:05. Okay, thank you. I thought you were not happy about it. Anyone sharing beside me?
Can I replace my
We had a bit of food and drink for the tummy. So next up we have Dr. Ian Dunn. He's the colorectal surgeon from NUH as well as Alexandria Hospital, head of the colorectal service in LAX. He's going to present to us about laparoscopic appendicectomy. Yeah.
Thank you. Thanks, Sean. Thanks to Dr. Marcos and Sean for having me here today. So the talk today is on laparoscopic appendicectomy, but I don't think you guys need to learn how to do a laparoscopic appendicectomy. What really differentiates a senior surgeon and someone who's done this procedure many times is really about the decision making and what you do in certain situations, and also the ability to identify potential pitfalls. Okay, so that will be the focus of the talk today. We'll start with a quick introduction, and then we'll go into port placement, the ergonomics of port placement, how to locate difficult appendix, how to control the mesoappendix and the appendiceal artery, how to secure the base in different circumstances, depending on what, how healthy the base is, how healthy the cecum is, what's the relation to the terminal ileum, as well as how to manage spillage. And also a question that always tends to cross our mind when it's a difficult appendix is whether or not this patient needs conversion to open surgery. So appendicitis is extremely common, 7 to 9%, and I'm sure you've done many appendicectomies in your lifetime. Okay. It's a bread and butter surgical operation, but we do know that of the 17 million cases that are seen globally, there are some which can be quite complicated. Okay. And the laparoscopic approach is the standard of care with less wound complications, faster recovery due to less pain, less incisional hernia, etc. So we all know the steps. First is port placement. Second is to delineate the anatomy. Third, to divide the appendiceal artery. How to secure the base. But what would help us to get better with this simple operation is really to look at the different steps and try and optimize them and how to make the best surgical decision based on the different operative steps. So with the port placement, it's really about what port placements are going to give you the best ergonomics. You need to delineate anatomy. It's really about trying to find the appendix when you have a difficult case. How to divide the appendiceal artery is about different ways to tackle the mesoappendix, as well as how to secure the base in a difficult case. So this is how I place my ports. It's quite a standard way of doing the appendicectomies in Singapore, where we put a 10 millimeter Hassan stroker in umbilical, 2 working ports in the left iliac fossa and 1 in the suprapubis, 5 millimeter ports. And the camera port ends up being about L4, okay, which is roughly, the dome of the abdomen when you do a pneumoperitoneum, which gives you a good bird's eye view, and also it allows you to really just see the appendix straight on. I place my ports 1 fist width from each other, and this allows me to have good triangulation between my ports. Okay, so I don't use any bony landmarks when I do laparoscopic surgery. I put in my camera port first, and then I look at the domains. And I know if with these domains I don't go near them because I'm going to be limited by the bony prominences. And then I use my camera port to, and also what I find on diagnostic microscopy, put my ports in. So there's no hard and fast rule. It's really about what you see in the case and how you adapt to it. Okay. This allows me to have access to the cecum. Okay, and you see there's no instrument clashing. I have access to the pelvis to perform a good washout. And with these ports, I can also perform a lap right hemiplectomy if that's called for. So how do you identify where the appendix is? I mean, we talk about our time. 90% of the time, the appendix is super straightforward, but you guys are not here to learn how to do that. You guys want to know how to do it. It's difficult. And the first thing is to delineate your anatomy and identify where the appendix is. I'm sure that we've had cases when we were growing up, we were learning and training, can't find the appendix, you can't start the operation, you don't know where the appendix is, right? So we need to know where the common locations are, and majority of patients have a retrocerebral appendix. Okay, 64% patient retrocerebral appendix, 32% have pelvic appendices. Okay. So I have those the residents who have operated with me or even done the procedures with me, I have a stepwise approach to everything, and I follow that all the time. And for appendicectomy, this is my approach. Okay, the first thing is I demonstrate anatomy. I know where the cecum is, I know where the terminal island is, and once that is sorted out, I kind of know where the appendix will be, or roughly the region where the appendix will be. And also it eliminates the guesswork, because if I'm going to do some dissection, and you know, in difficult appendices, you need to do blunt dissection, hydrodissection. If you know where the vital structures are, you're a bit more confident in your dissection. You can push harder in certain areas and know where to back off without causing any injury. One thing I learned is to follow the information. Sometimes you can go into the RIF, right fossa, try and find the appendix because you look at the wrong place. Sometimes the appendix can even be subhepatic. So follow the inflammation, let the body guide you to where the appendix is. Okay. Follow the convergence of the tinea coli. You can't see the appendix, you go to the cecum. And then you see where the tinea coli converges, and that is where the appendiceal base is, and then you follow that to the tip of the appendix. Sometimes you may need to elevate the terminal ileum because it can be hiding underneath the terminal ileum. Inspect the pelvis, subhepatic space, because the appendix can lie there as well. And in some instances, when you can't find it despite all the above, you may have to mobilize the cecum from a lateral to medial approach because it can be retrocecum. Okay. And we know that poor identification will correlate with a high conversion rate. Can't find the appendix, have to convert. Injure something because we are not looking in the right place, we have to convert. Okay, so I always tell the residents it's okay to spend time on this step because it makes every subsequent step much easier. Mesoappendix control, the appendiceal artery lies in the same place all the time, doesn't change. Okay, and it lies at the apex, or rather the tip of the flag or the mesoappendix. Okay, over here, it always lies over there. Sometimes, you know, the resident may say, "Oh, I can't find it. It doesn't exist. It's thrombosed off." It's not true. It's always there. Okay, and the first step is to create a mesenteric window. I like to create my mesenteric window right here at the base, okay, so that I just clip it once. Sometimes if it's ligated too distally, you end up finding it here again, and you have to ligate it here again and waste your time, double the work. So I tend to ligate it right at the base of the appendix. I ligate it once and it's done. Okay, so the first thing to do is to create the mesenteric window. You have to score the peritoneum first, okay, because if you don't score the peritoneum, no matter what dissection you're going to do, it's not going to split the peritoneal layer. Just score the peritoneum, you get to the subperitoneal fat, and it's much easier to create your mesenteric window. I like to use the Maryland forceps because the Maryland forceps has a fine tip, it's curved, okay, you kind of go around the vessel, and also it's a bit sharper than your straight bowel graspers to allow you to get through. Once that is done, I skeletonize the vessel, and then I secure it with the Kimberlock clip. You don't really have to skeletonize the vessel because it's super small. And if let's say you run into trouble and you just don't want to create a window, no, you can't really get a window, you can just clip it, it will still be secured. But it's good practice for junior residents to try and skeletonize these vessels because it will allow you to gain the skills to do your lat choles, your anterior sections, brachiocolectomies later in your life. Okay. Now, what happens if you really can't find it? It's a mess. There's another way you can do it, and this is to fillet the appendix from the mesoappendix. Okay. I do it sometimes where the vessel is not really well seen, or whether it's sometimes stuck to the cecum, terminal ileum. I don't really want to go dissecting those areas. I start at the tip of the appendix, and then I hug the wall of the appendix, and I fillet it down to the base. That's because these terminal vessels here are extremely small. Just a bit of diathermy to burn them would be more than enough to achieve adequate hemostasis. And I do this to the cecum to get to the base. Okay, so this is mesoappendix control. Now, securing the base can be done in two main ways. One of them is to put in endoloops. Okay, endoloops can, like in this photo over here, they can either be Prolene endoloops or they can be Vicryl. Okay, both are fine. Vicryl ones tend to be a bit cheaper. They are much easier to control because they are braided, but sometimes if it's wet, it gets a bit sticky and it's a bit messy with the micro. I like to use the Prolene endo loops because they go over easily, they slide nicely. It's really your preference. Okay. Another way in which the base can be secured is to use a Hemlock clip and just clip across it. That's fine as well. As long as the main principles are achieved, it can be done. And the main principles are to get a good closure of the base to prevent a appendiceal stump blowout. But what happens when the base is difficult to secure? Okay, there are four main situations that you may encounter. The first is if the base and the stump are both healthy. What do you do? Okay, you can see over here, and you need to translate the appendix over here. This is what we see in 90% of appendices. All we need to do is to put in an endo loop, okay, right over here to secure the base, and that is done. Because you're not worried about a unhealthy base or unhealthy stump. But what if the stump is unhealthy? That means the stump is unhealthy over here, but the base is healthy. What can you do? Okay, if you were to put the endo loop here, it's an unhealthy stump, there's a risk that number one, the endo loop may cheese wire through, cut through, you get a hole in the cecum. Or even if you secure the stump, if it necroses off, you will still get a stump blowout. So in that instance, what I like to do is I put a purse string after securing the stump here with the endo loop. I do a purse string and I bury the stump. It's kind of like when we do the open appendices, we bury the stump. But over time, I personally feel that the purse string has a higher tensile pressure and strength, and I don't quite like it because if one bit of the purse string gives way, the whole purse string gives way. And what I like to do is I do Lambert intraocular sutures. Okay, so I take a suture on one side of the cecum and come out and come to the other side, and this allows me to bury the appendiceal stump. And I do a couple of stitches to stitch it quite nicely, it's quite fun to do. And also, I like to do it interrupted because even if one gives way, the others are still there to give it strength. So now what happens if the base is unhealthy? Okay, that means even if you put an endo loop, even if you bury the base, you're trying to stitch through it, the base of the cecum, the base of the appendix, and the cecum is unhealthy. You can't put stitches in, cheese wires through, or you're worried that's going to give way. What are you going to do? You can do a cecectomy, okay, and that's the way to secure it. And this is for those who haven't done a cecectomy before, you do it with a linear stapler, okay, and you have to kind of convert your operation a little bit, okay, because we start off with a 5mm port in the left iliac fossa. You have to upsize it to a 10mm port because your linear staplers are 10mm in size. The next thing you need to do is you need to mobilize the cecum. Why do you need to mobilize the cecum? It's because you want to fire the stapler across the unhealthy cecum over here, okay, where you get healthy tissue over here. And if you don't mobilize the cecum laterally, there's no window for your stapler to go across. So you need to mobilize the cecum as well as the ascending collet with a lateral to medial approach, just to make sure you have a completely mobile cecal fold. And once that is achieved, you can put in the laparoscopic linear stapler from this port, and it's pretty much a straight shot to the cecum. Okay. But your left hand is extremely important in this instance because you need to pull the appendix and the cecal pole inferiorly. Okay. And not only do you want to pull it inferiorly, you want to pull it anteriorly towards the anterior along the wall, so that you have enough space to put your stapler below it. If you just pull it downwards, there's no space posteriorly. You need to pull it towards the 11 o'clock and pull it hard to get a good staple fire across. But what is the critical step is that when you put the linear stapler through, you need to make sure that the terminal ileum and ilicecal valve is not compromised. And that's where the left hand is extremely important because it straightens everything out from here to give you a nice landing zone to fire across. Because if the terminal ileum is compromised, it's going to get patient's going to get ileocecal IC valve stricture. But what if we are unable to get staple fire across because, let's say, this part of the sequence are healthy is too close. Then in that instance, we may need to do a limited right hemiplectomy. Okay. But whenever you're doing that, the question that you need to ask yourself is that preoperatively and intraoperatively, does this look like a cancer to you? Because if it looks like a cancer, the limited right hemiplectomy is not the operation you want to do because you don't get the adequate lymph node clearance. Okay, but if it's quite clearly appendicitis, a limited right hemiplectomy, okay, will suffice. All right, and it kind of looks like this. So you just remove a bit of the cecum and the ascending fluid. So how do we manage spillage? Okay, so spillage, I'm sure you get in situations where it just looks very messy like this. Okay, one thing that I do is that I perform suction before any irrigation because when we irrigate, we lose control, things spill everywhere. The patient in this situation is usually in a head down, right side up position, and all the liquid and pus and fluid that you're flushing is going to all go to the left hypochondria, which you're not going to look at during this operation. Okay, so try and suck everything dry first before irrigating. Limit unnecessary irrigation, as well as it's very important to remove any fecaliths or any bits of feces that may come out after you cut the appendix or are floating around because it's perforated. You can either use the suction to suck it out, but sometimes it doesn't work. You may have to place them strategically so that when you put in the bag to remove the appendix, you can place all of them into the bag as well. Sometimes, if the contamination is bad, you may just need to convert. Because if you laparoscopically you cannot get good abscess clearance, you're unable to do a good washout, it's okay to convert just for the washout. The appendix may be out, ready to be bagged, but you just can't get enough good wash. It's okay to convert to wash because you don't want the patient to get any post-operative abscess formation. Okay. So when do we need to convert to open? As we discussed before, if you are able to manage the spillage adequately, laparoscopically. But very often we have to convert because, let's say, it's just dense inflammatory mass, we cannot get any dissection going. But then we need to think backwards a bit and decide, was it really the correct decision to go in for this patient? Because we know phlegmons can be treated like antibiotics first. And then later on, we do a repeat CT scan to look for resolution, and then decide this patient may not need a appendectomy at all. Okay. So it really comes down to your preoperative decision on your physical examination findings. If you feel a mass there, usually a phlegmon, it's walled off. Unless the patient is septic or toxic, you don't have to go in and give the patient antibiotics. Or on the CT scan, you find a huge, not on the CT scan, but you find a huge phlegmon. Okay, that also is probably not the right case to go in for surgery for. If the anatomy is unclear despite all the approaches you've done, it's okay to put in another port, a system port to give you adequate retraction. And lastly, sometimes, if you see this on a CT scan, okay, it's an appendiceal mucosal. And in such a situation, it is crucial that you do not have any spillage of the content, because this would lead to pseudomyxoma peritonitis. So it's reasonable to convert to open where you have better traction and control with your left hand to do the operation without spillage. Take-home messages, okay, is always to set yourself up for success. It starts with a decision to operate or not to operate, how you place your ports, how you delineate the anatomy, how you respect the base of the appendix, the stump of the appendix, how to manage spillage. It's also very important to cut the specimens open because then sometimes if it's not very clear, there have been instances where the histology comes back and then it's just some appendices epiploidy or fat that has been removed. You need to cut the specimen open if it's not certain and ensure that there is agreement to confirm that you have indeed removed the appendix from this patient. And lastly, decision making is key. At every step of the way, what will differentiate a person who's doing the appendix for the first time or someone who does it well is really about decision making. And very often when, as a consultant, when you go into theatre to give your resident a hand for an appendix, you're probably not scrum. You're just telling them what to do. It's because the technical skills of dissecting are not difficult, but the decision making is key. Okay. All right. Thank you.
Dr. Ian Tan. So our next lecture speaker will be Dr. Sean Lee. He's one of our very own hernia center specialists. So we'll be discussing about ventral.
Okay, hi, good morning everyone. So last half an hour of the morning, we're gonna just try to speak a bit more quickly on ventral hernia repair. So I'm Dr. Sean Lee, I'm from the surgery department here in NUH, and I also teach a bit in the university. So talking about ventral hernias, okay, so first of all, there are certain key factors that affects whether your ventral hernias are successfully repaired, right? Just a simple patch, throwing on a mesh doesn't work all the time. So you have to think about not just the anatomy, but the physiology of the abdominal wall. Okay, we do want to ensure that there's restoration of the abdominal wall continuity, and we emphasize the recreation of the linear elbow with primary fascial closure. Okay, in other words, always try to avoid a bridging repair. So we also want to preserve both the blood supply as well as the innervation. Okay, you know the innervation comes along the lateral edge of just slightly medial to where the linear cellular is. And also we want to, of course, provide a long-lasting repair after our mesh repair. We always want to repair with minimum tension. Okay, we know that from studies from decades ago, from first described inguinal hernia, subsequently ventral hernia, that repair with tension should be avoided. You try to repair with minimal tension. That's why the mesh helps us to achieve that. We also want to try to minimize the dissection space as much as possible. Okay, think about those on-lay meshes, right? Those require a lot of subcutaneous dissection, and that can lead to a lot of seroma formation. So minimize the dissection space, do just what is needed. You don't need to do a bilateral TAF for every single case, right? You just need to do what's needed, and of course, always consider the wound length. We do advise that if you want to get into this realm of hernia surgery, you want to be comfortable in doing it, you need to have a series of techniques. You need to have a whole armamentarium of techniques and not just a one-trick surgeon. You don't just do the same thing for all patients. You want to individualize your treatment, your techniques based on the patient's needs. Okay, so I'm just going to speak a bit about the different surgical options available. Okay, there's the open surgery, of course, which a lot of us are familiar with. There's laparoscopic, and of course nowadays there's robotic surgery as well, but I won't go too much into that. Within laparoscopic, there are a whole bunch of various techniques over here. I myself, we don't practice all of this all the time. But we tailor like I said, we tailor it according to our patient's needs, right? According to the characteristics of the hernia, according to the comorbidities that the patient has, including whether it's a primary surgery or recurrent surgery, etc. So I'll go through some of this as we go on through the later slides. The diagram on the right is absolutely important. Now we have some junior surgeons back there, our residents. So absolutely important that you know the different layers. Okay, it's not just skin, fat, muscle, and then your intestines. Okay, so you need to know the different layers, right? And you will always hear the term onlay, inlay, and sublay, right? And sublay further divided into preperitoneal, retromuscular, and intraperitoneal. Okay, some people call it the underlayers. Many techniques, okay, and over the years, evolution and revolution, right? And you read some of the latest evidence and the latest guidelines. EHS is also pushing for a tendency to position the mesh in an extraperitoneal layer for some of the complications, the long-term complications that we see with intraperitoneal meshes, and that will include like mesh erosions and mesh fistulation to the bowel. Okay, so right from the bottom, the open surgery, then we move on to IPOM repair when Dr. Carl LeBlanc first described it. Then we spoke a bit about closing the fascial defect, right, making that the IPOM plus. PPOM is, I'll go through that, I've got a video later, but it largely is a similar concept to the inguinal hernia TAPP. And then of course there's ETAP, which is all popular and the craze right now in the hernia world. Okay, I'll show a video later. So TAPE, we have a video later. It's quite similar to TAPP, just that it's partially extraperitoneal, partially intraperitoneal. Scola is a subcutaneous only dissection used quite commonly in South America and mainly for a lot of patients with rectus diastasis or very small umbilical hernia. Melos is described by a German surgeon, and he has done like thousands of cases with fairly decent results. So a trans hernia approach, basically dissect into the hernia sac itself, get into the preperitoneal or retrorectus plane, and then perform the surgery either through a small open surgery or an endoscopic surgery. Okay, CS is component separation. Ramirez first described it in as the anterior component separation, and then subsequently posterior component separation was described as well. And then of course the new stuff that we are dealing with is Botox injection as part of what we call a chemical component separation. But some of that is beyond the scope of what I'm going to talk about today. Okay, so we start off with something simple. I've got quite a few videos, so some of them I'm going to try and jump through. This is dealing with a very small umbilical hernias. So usually we're doing open surgery for this. So usually up to a hernia defect size of about 3 to 4 centimeters, we still offer our patients open surgery, right? We don't really see much benefit of doing laparoscopic surgery for these patients. 3 laparoscopic surgery, 1 CME is the same as 1 3CM incision. That's our simple mentality. So you just get it done, just do either an infra-umbilical incision, dissect down to the hernia sac, okay, isolate the hernia sac, make sure you don't damage the umbilical stalk, or make sure you don't damage the skin, you don't buttonhole through the skin. Like I said, go around the hernia sac, go around the neck of the hernia, get it properly delineated. Jump through a little bit. This is the mesh that we use. It's a ventral patch mesh. Okay, and you can see later it comes with 2 anchors. Okay, there are various. There's another brand out there that there are 4 anchors, but it's conceptually the same. Okay, these meshes are actually coated meshes. They are coated meshes. There's an anti-adhesive barrier at the inferior surface of the mesh. That would be the bowel-facing side of the mesh. Okay, so it's once you got the hernia sac dissected, you enter the hernia sac, you ensure that there's no bowel or no adhesions intraperitoneally. You put in a finger and you do a nice finger sweep 360 degrees, make sure there's no bowel stuck. Then you put in this mesh. Okay, this mesh, like I said, there are 2 straps that comes out like this. The straps come out of the abdomen, and you make use of the straps to lift the mesh, to pull the mesh up against the anterior abdominal wall while you suture these little straps down so that your mesh will move. Okay, and then at the end you just close up the fascia, close up the skin. Okay, so quite simple and straightforward. Then we move on to laparoscopic surgery, right? IPOM, I think a lot of you are familiar, a lot of you have heard of this term before. It's the intraperitoneal onlay mesh. Okay, it's probably the first described laparoscopic repair for the ventral hernias, right? Subsequently, years later, like I mentioned, the IPOM plus, okay, it's advocated for, and that would be the closure of the fascial defect. So you close the defect first laparoscopically, then you put the IPOM mesh. Okay, so you see the little diagram on the right hand side just showing you the different kind of tensile forces if you close the defect and you don't close the defect. So by and large now, I would say all the 99% of the time, 100% of the time, we actually try to close the fascial defect. Okay, so that will help us by decreasing seroma risk, decreasing the risk of mesh eventuation, the mesh going into the hernia defect, and ultimately you're changing a bridging repair to actually a proper mesh repair. Okay, because if you don't close the defect, there's actually literally a hole there. There's no fascia, right, in that hole, and you're just putting a mesh over. Okay, so now it's recommended that you close the fascial defect. So this we basically convert, like I said, we convert a bridging mesh into something called mesh augmentation, which is what we're trying to achieve. Okay, there are different ways to close the fascial defect. Okay, I think this diagram, this small little video on the side is actually showing intracorporeal suturing with a barb suture. There's V-lock available. There's a strata fix available. Some surgeons have preference for non-absorbable sutures. Some use absorbable sutures. I myself, I use a non-absorbable sutures, but sometimes there's some contention as to whether that causes chronic pain. But this is one of the techniques to close the fascia. The other technique, which is the first one on the list actually, is the transfascial suture, which we'll see in some of the subsequent videos, whereby you make use of a suture passer to help to pass these sutures through. Okay. Sometimes we do a combination of both, right? For the very the larger defects, we do transfascial suturing first, and then we reinforce with a running barb suture. Okay, and for the reasons below, lower seroma rate, lower mesh evacuation rate, and lower recurrence rates. Okay, it's a 5-minute video. I will jump through it so it doesn't take 5 minutes. This is one of our cases a couple of years back. It's an umbilical hernia. You will see later, probably ask me a question why I did laparoscopy for this patient. But here it goes. So this is an example of optical entry, right? Dr. Noor mentioned just now. Optical entry is one of the techniques to gain access to the abdomen. So we made use of XL 10-12 port, and in this case we use a 30-degree scope to do the entry, abdominal entry. So you see that there's a lot of fat stuck in the anterior abdominal wall. These are all pre-peritoneal fat. So his hernia was, I think, was a 60-year-old. He was a Caucasian gentleman. His hernia was filled with pre-peritoneal fat. It was not filled with any intra-abdominal organs. So you can see as we dissect around it, we use blunt dissection so that we can see clearly. We know what we are cutting, then we can use a bit of diatomy if needed. Okay, and we're fairly safe because we can see very clearly that the bowels are all down. Okay, so we dissect around the hernia defect. Okay, and you can see, actually this is the hernia defect. It's not too fantastic, not too huge, right? At most probably at most about 2 to 2 centimeters, I would say. But the reason why we actually opted for a laparoscopic approach for this gentleman was because of his size. So I do take that into consideration sometimes, right? Like I previously said, less than 4 centimeters, we can usually get away with open surgery, right? But for patients who are a bit with a higher BMI, right? Sometimes we opt for laparoscopic surgery as well to reduce the risk of wound morbidity. Okay, so you see this part I'm actually catching the pseudosac. Okay, not the pseudosac, the hernia sac. I'm catching the hernia sac from the inside. So I get an instrument in to pinch onto the hernia sac, the apex or the fundus of the hernia sac, pull it down, and during my intracorporeal stitching, I just take a few bites of it. Being very mindful not to touch through the skin. So always ask my assistant to look to see whether they see any blue color V-lock suture on the outside of the skin, right? And sometimes they really need to look quite hard because the RP plunges in. Okay, so we suture it close in this case with barb sutures. Okay, so here we're just giving some local anesthesia and filtration. Okay, we're making use of the Echo PS mesh. This mesh, some of you may have seen it before, but from what I know until now, this is the only mesh in the industry that has a positioning system. So you can see that this mesh, you see the green color thing there is actually a balloon, right? This balloon is connected to that external catheter, whereby we pump just atmospheric air, just room air in, and the green color balloon fills up. And that keeps the mesh open, and you're able to control and then just lift the whole mesh up to the anterior abdominal wall, and you just fire your tactics. But always remember to remove the green color balloon at the end of the surgery. It's not meant to be left inside the abdomen. There was a surgeon in our hospital who tried to use this, although he didn't know how the mesh worked. And he actually called me in trial and said, Sean, what do I do with the green balloon? I said, please take it out, don't leave it inside the patient's abdomen. Okay. Next up. So going on a bit about ETAP, because everyone is talking about ETAP these days if you're in the hernia scene. ETAP RS. ETAP stands for the Enhanced View Totally Extraperitoneal Approach. RS is, of course, the very traditional method, the brief SOPA method in open surgery. So a lot of them, when you're dealing with a ventral hernia, and the technique, laparoscopic or robotic extraperitoneal technique, we make use of the ETAP RS technique. Okay, so you can see this patient actually has a not that huge umbilical hernia, but he does have a fairly significant rectus diastasis. And studies have shown that if you have a concomitant rectus diastasis, you should repair it together with the umbilical hernia. If you only repair the umbilical hernia, you predispose the patient to getting a recurrence if you do not repair the rectus diastasis. Okay, the picture on the right, or the photo on the right, you can see that we're making use of, in this particular setting, we're using a robotic surgery. This is the Da Vinci system which we have here in our institution. This just shows part of the zeroing of the robot. See the green color crosshair. Okay, I don't think we need to. Yes. Okay, just very briefly, some of the surgical steps in ETAP surgery, right? Whether you're doing it through a laparoscopic means or robotic means, the steps are fairly similar. Okay, first of all, you gain access into the retrorectus plane, or in other words, the ETAP plane. This can be done through open dissection, making use of your surgeries and getting down into the plane, or some more or less nowadays we always use the optical entry, whereby we poke through the anterior rectus sheath, get through the muscle, then we see a bit of white, which is the posterior sheath. We angle our trocar, and then we insufflate to get into the retrorectus plane. Okay, you develop the retrorectus plane on that ipsilateral side of the rectus. Okay, and then the third step will be to perform the crossover. There's an epigastric crossover, there's a suprapubic crossover. I would say probably most people will do an epigastric crossover. You make use of the natural, the innate falciform ligament as a bit of a buffer, not to get into the intraperitoneal cavity when you cross over to the contralateral side. Probably the toughest part of the surgery. Okay, to do it smoothly and to do it correctly. Once you get over to the contralateral side, you connect both retrorectus plane, you dissect the contralateral retrorectus plane, and you get both retrorectus plane fully dissected. Okay, down laterally to the linea semilunaris. There's closure of the posterior rectus sheath. Some would say that it's optional, but what is truly crucial is if you see any defects in the peritoneal lining at the base, you have to close them. Because most of the time we put an uncoated mesh, so make sure you close up any small folds which were inadvertently created. Then you go on to close the anterior rectus sheath, and then you measure the size of the cavity, put a plain uncoated mesh inside. In our institution, we usually leave a drain at the end of the operation, and we take it out at about day 5 when we see the patient back. Patients usually stay for about 1 to 2 days after surgery. We go home and we see them about most of day 5 in the clinic to remove the drain. And the drain is left within this ETAP plane or the retrorectus plane just to drain out some of the extra fluid to reduce risk of seroma. Of course, and we desufflate the space under direct vision just to make sure your mesh does not migrate in the process of desufflation. Okay, so those are the steps. I described it more clearly in particular because it's a newer technique. So this is a video of how we did the ETAP. Okay, sorry, just show you the CT scan again. Okay, our board placements, we usually start on the lateral, right? How it was first, on the left side, like how it was first described. We gain access into the retrorectus plane, as I mentioned. In this case, this is a video of a laparoscopic ETAP. You can see that the space in this video is not great. Okay, perhaps I think there was a bit of pneumoperitoneum that actually went into the intra-abdominal cavity. So you can see that the base of the screen, your posterior rectus sheath, tends to bulge up a little bit. Okay, it can actually be circumvented by using your left hand or your non-dominant hand, gently pressing down to try and give you that little bit of extra space. Okay, so this is the crossover. You see the yellow fat there is part of the crossover. Okay, the falciform ligament. In this case, the umbilical hernia was still quite badly incarcerated with fat, so we decided to open a hole in the posterior sheath and the peritoneum so that we can do reduction of the omentum. So there was quite a bit of omentum that we had to reduce. And I always tell the juniors, the MOs, and the registrars who scrub with me, this is probably the most satisfying moment of a hernia surgery, where you keep on reducing power or momentum, right? Quite fun, to get all this stuff out of the hole. Okay, the little joys that we hernia surgeons get. So subsequently dissect, okay, subsequently we dissected into the contralateral retrorectus plane, okay, get a nice and broad dissection on both sides. Okay, ensure all these attachments are all dissected down. Okay, get a nice space. In this case, we actually employed a transfascial suture closure of the anterior rectus sheath. You can see this instrument that we are using is a suture passer, and we are using proline 1 sutures to actually put them in an interrupted fashion to close the fascia. Of course, the other technique is just to use the intracorporeal suture. Okay, so we dissect. There tends along the linea alba there tends to be a bit more adhesion. So just ensure you get enough space superiorly and inferiorly. Right, this part we actually, because the posterior sheath had we went through the posterior sheath to reduce the hernia, so you can see that we're closing it right here. Okay, in this case we use a mesh. This is a pro-grip mesh, which is a self-gripping mesh. Small, if you look very closely, there are these small little spikes on the mesh that actually hugs onto the rectus muscle quite firmly. So when you place a mesh, the good thing about ETAP over IBOM is that you can use a plain mesh. In other words, an uncoated mesh, right? And uncoated meshes are much cheaper than coated meshes, and typically does not require any fixation, right? We do not use absorber tags to secure the mesh, because within the ETAP plate, within the retrorectus plate, it's quite unlikely that your mesh will run into 200 shots. Okay, lateral flank hernias. Okay, I've gone on for quite a bit already. I'm just going to zoom through a bit more. Not very common. Okay, but perhaps just show you a bit of the technique. Okay, in this case, we are doing a TAPP, or what some other people call a PPOM technique. It's basically just opening a peritoneal flap right here. Okay, and then that flap is where the hernia is. All right, and then likewise, similar concept. You close it. Okay, either with suture passes or with V-lock sutures, and then you put a simple plain uncoated mesh. It's just a very regular polypropylene optidine mesh. Okay, and then of course you close the flap. On to the next slide. Suprapubic hernias are always very tricky. Okay, and we get this quite a bit in our female patients who have previous cesareans. Okay, our gynecologists are always very kind to us. They keep us in business. They give us incisional hernias. So suprapubic hernia is something that you must be fairly confident of how to repair. Okay, in this case, we use a TAP technique, which is a mixture of a TEP and a TAPP essentially. So in this case, similar concept. You create a flap, you dissect, you put the mesh. I'm just going to zoom through. Okay, conceptually it's the same. You put a mesh over there. This is usually a coated mesh, because half of the mesh is still left intraperitoneal, half of the mesh is actually extraperitoneal. The benefit of this in the suprapubic region is that you're able to put the mesh even further down, right? Imagine the groin dissection, right? You can go all the way down into your space of radius, and the mesh can go all the way down there, and you know that you can pack it very firmly onto the Cooper's ligament, right? So that's the benefit of the TAP. All right. Okay. Surgical options. Yeah. So I mentioned all of this already. Yeah. Various muscle relaxation techniques these days beyond the scope of today's talk. Okay. This is the same slide. I think you might have seen this in Suji's lecture already. But we both Alexandra and National University Hospital will make use of this infogram to educate our patients on what we can do after laparoscopic surgery. Okay, much faster recovery compared to open surgery. Abdominal binder is what we get our patients on to wear, right, when they are post-ventral hernia repair. Okay, just a bit of evidence. Okay, I won't take up any more time. Thank you.
So I'll be introducing our next speaker, who's going to be tackling dental hernia repair. We have Adjunct Assistant Professor Ted Junian. Upper GI surgeon from J. Fong General Hospital and did further subspecialties in advanced endoscopy, ERCP, and US bypass from Prince of Wales Hospital in London.
Right. Thanks for the introduction. Thanks for having me. I'm glad to be here to speak to you guys about the techniques in hiatal hernia repair. Yeah, unfortunately for hiatal hernia repair, it's quite a varied topic, and we need to take care of both the functional aspect of things as well as the organic part of things. But I'll try to keep it simple, bearing in mind that this is giving you between lunch. So anyway, for hiatal hernia, it's important to understand the classification of hiatal hernia. So we've got a few classifications. I think traditionally we always talk about the Hughes grading for hiatal hernia, which is divided into grade 1 and grade 4 to grade 4. But then it's not very specific and it's very operable, dependent. I think we also know that most of us who are surgeons classify hiatal hernia between type 1 to type 4, type 1 being the sliding ones, type 2 and 4 being the paraesophageal hernia that usually will require surgical repair. More recently, the American Thoracic Society has actually championed the use of EFS grading, which actually takes into account the axial length of the hernia, as well as the hiatal aperture, as well as whether the flap is still intact or not. And it's somewhat similar to the Hughes grading, but it does give a little bit more objective classification into how to grade hiatal hernia. So obviously the bigger hiatal hernias tend to be more symptomatic. Usually the grade 1s or the type 1 hiatal hernias generally do not require surgery, but it really depends on how symptomatic the patient is. So if you follow the SAGES guidelines, the indications of hiatal hernia repair unfortunately is rather big in the surgical literature, but basically the consensus that we generally have are that symptomatic paraesophageal hernia should be repaired. Patients with refractory GERD should also consider surgery. However, this must be taken in the context of also functional testing, because we know that patients with GERD symptoms, which is refractory to PPI therapy, may also not do so well after hiatal hernia repairs or fundoplication. Of course, hiatal hernias can result in complications such as anemia from camerinosis. They can have bulbous and so on, and these are the group of patients that may actually require emergency repair. Of course, we all know that GERD surgery is pretty much a quality of life-driven decision. So younger patients with functional testing that is suggestive of excessive reflux and so on should also have fundoplication and hiatal hernia repairs. So I think the recent SAGES guidelines they do talk about 4 key points, and the first is with regards to the use of mesh, and unfortunately no consensus was achieved on whether we should use mesh for hiatal hernia repair or not. Asymptomatic repair, for asymptomatic parallel esophageal hernias, they actually recommend that you should have a discussion. But I think in surgical literature, we usually tend to repair this patients, especially those with symptomatic type 2, type 4, as we mentioned. Fundoplication, it's recommended that we should perform fundoplication in the same setting, as that probably will reduce recurrence risk. And it's a special situations such as redo or recurrence, we should really be considering whether we should, instead of re-repairing the hiatus, whether RIGP or rural-wide gastric bypass is indicated, especially in patients with 5 and 9. So for preoperative evaluation, I think we need to know about the certain modalities that we do. The bread and butter is really the upper endoscopy, and it should really be adequate in trying to understand what is hiatus hernia, because there are several terminologies and several compounding anatomical interpretations. And what you really have to appreciate is where the sphenocolumnar junction is, where the diaphragmatic hinge is, and if you follow the Japanese guidelines, they'll usually look at where the palisade vessels of the esophagus end. So that's probably the true GE junction. So if you take the distance between where the palisade vessels end and where the diaphragmatic hinge is, then that will give you your axial length of the hiatus hernia. So high resolution manometry and pH impedance testing is not really always indicated for hiatus hernia repairs. In patients with very bad esophagitis or big hiatus hernias with very classical reflux symptoms, you should probably repair them without this testing. But in borderline cases, we can consider using pH impedance testing to assess whether that's acid reflux or not, and also high resolution manometry, because that will give us an idea of whether there's the motility of the esophagus, and that may impact what kind of fundoplication we do. Because in some patients with very poor esophageal clearance or very poor or ineffective esophageal motility, then we should probably not do full fundoplication for the patient, because that may result in quite a bit of dysphagia for the patient. Of course, in this day and age, barium solo is less indicated because of all these other good modalities we have. I think on the pH impedance, on the manometry, we can actually also appreciate the presence of a hiatus hernia. You can see here, you can see that there are two pressure bands here. So one is the low esophageal sphincter, that's a high pressure area. And you see another high pressure area near the diaphragmatic hiatus. So if you see that there's a big distance between the two pressure bands, which classically, if there's hiatus hernia, then you should see that there's a separation of 2 centimeters. For most patients without a hiatus hernia, you can actually see that the low pressure band, the high pressure band, and the low esophageal sphincter actually coincides quite close to the diaphragmatic hiatus. So very quickly, I just move to how I do my hiatus hernia repairs. Generally, I do it through So I usually use a 5-port technique, usually on the. Okay, so usually I do optical entry through the left umbilical area, and then from there I usually use 3-5mm ports. Sometimes I use a trowel because that allows me to introduce my sutures more easily. So it's usually 2 working ports and 1 assistant port, as well as a double retractor. I usually have the patient in a supine position with a footboard and the patient in 30-degree head up position. So it's important to strap down the patient so that they don't slide off the bed. So very briefly, the principles of the hiatus hernia repair, really when you dissect it, you need to achieve a full mediastinal dissection. You need to circumferentially mobilize the esophagus, excise the sac, and try to avoid bitterness injury to avoid any functional symptoms. So for aspiring lab surgeons, you should know how to do a optical entry safety. So you need to appreciate, like what Sean mentioned, the layers of the abdominal wall. So you can see we reach the anterior and posterior sheath now. And when you feel this sleeve, then you need to stop and you need to reassess because you're most likely in the peritoneum already. The initial setup of the operation is quite simple. You really just have to put in the level retractor and then put in your working ports, which is what we showed just now. In the just on the right side of the patient, on the right flank. So one here and this one usually next to the possible ligament. So I think that there are certain benefits with doing it in this position. We do using this setup, then as opposed to the classical legs open, camera in the middle, through the umbilical port and having two instruments on both sides. I think that the benefit is that number one, it's easier to set up, so you don't have to be catered so early on, and you can have the junior set up in the supine position quite easily. And also, usually this, if you are as with practice, you usually can actually achieve the hiatus quite well. One of the fallbacks is that you do need to place your posture rather high because you are dissecting the hiatus. So even though we may think that the hiatus is, where the CP sternum is, usually is actually much higher. So you have to try to, usually I think that I usually put a palm directed just below the nipple line. And that's where my pulse will be usually quite high. So just a few videos. So it starts with it starts with the hiatal mobilization. So instead of for big hiatal hernia, I think the fallback is that I think traditionally people would try to reduce the hernia set, and you think that or reduce the intra-abdominal content of the stomach for the hernia set and so on. But usually you find that that's not very helpful, and because of intrathoracic pressure and so on, usually the structures keep going back. So generally, it's much easier to open up the cranial-esophageal ligament, dissect in the pit between the mediastinum and the hernia sac. And usually, when you release these mediastinal adhesions, and usually this is through blunt dissection, the hernia sac can come down much easily. So one of the worries about doing this is that the hernia sac is actually intraperitoneal, but as you dissect higher, you actually reach the esophagus. So you do need to keep an eye out for the esophagus so that you don't injure the esophagus inadvertently when you are dissecting what you think might be the hernia sac. After that, it's just taking down some of this adhesions, which is actually quite simple to do, and it's just so these are usually very soft adhesions that can come down with just a little bit of energy. One of the other fallbacks is that sometimes the patients with very bad esophagitis or very severe or very chronic hernias, then we need quite a lot of revascularization and you may get a little bit bloody. So use of an energy device is sometimes quite helpful. So when you talk about hiatal hernia closure, posterior cryoplasty is really the standard. We advocate the use of non-exorbital sutures. Avoid over tightening and need to, as with any other hernia surgery, assess the tension and try to achieve a tension-free repair as much as possible. So how do we ensure? So one of the helpful methods is try to ensure adequate esophageal length. So when you perform the esophageal mobilization, you do need to extend it quite high up to the intestine to try to mobilize the esophagus as much as possible so that you get an intra-abdominal length. Intra-abdominal esophagus length about 3 to 4 centimeters. However, you do need to be careful, like what we mentioned before, of inadvertent injury to the esophagus. And while dissecting, you also need to be mindful that the pleural membrane is quite close by, and you may inadvertently enter the pleura and focus out in the pneumothorax if sometimes the hernia sac is very stuck. So you need to work with your anesthetist with regards to that. In esophagus where you cannot have adequate esophageal length, which is quite rare, we can actually do a cholecystroplasty. Basically, a cholecystroplasty will involve lengthening the esophagus. So you actually use a stapler and you staple this part and go laterally. So it's almost like a wedge resection of the fundus so that you increase the intra-abdominal esophageal length. There are certain strategies to prevent recurrence after hiatal hernia repair. I think Schneider published this the middle of last year. So basically, sequential closure of a big hiatal hernia defect, and he calls this the low tension triangulation method. So usually you first start off posterior layer. You close it sequentially. Sorry. You close it sequentially until this angle here reaches about 90 degrees. So when this angle is about 90 degrees, then the posterior chloroplast is actually quite high tension. So you slowly close off you then slowly close the anterior part, so that you kind of like achieve a equilateral triangle, or where the tension is equally distributed on all sides. Okay, so this video will actually demonstrate the posterior dissection. So a lot of times it's important to achieve all 360 all round mobilization of the esophagus, and sometimes you may have adhesions near the posterior part of the left crust, and you need to release this dissection. Usually I leave a gauze there so that you can dissect safely without being too worried about injury to the spleen. So you can see the vagus nerve here, try not to damage. And then you can just put umbilical tape over the GE junction, and you can pass this to the assistant who will be able to retract it laterally so that you can get access to the hiatus. Okay, this is another video that I wanted to demonstrate mediastinal dissection. So you can see that sometimes you have to go quite high, but usually the adhesions are usually quite soft, so they're not difficult to dissect. And here also you have to be mindful of apart from the esophagus, the aorta usually just rests immediately behind the esophagus, and sometimes there can be direct penetrating pressures from the aorta into the esophagus, and things can get a little bit bloody. So like what we mentioned before, the use of the energy device is sometimes helpful. So you can see in this case there's quite a huge hiatal hernia defect, but even in this kind of hiatal hernias, usually it can be primarily closed, and you may not always have to put a mesh, but we review the literature later with regards to the use of the mesh. Following that, then there's a closure of the hiatal defect, and generally we can do it using non-adsorbable sutures, or in this case, advanced sutures with pressures. So what the pressures will do is to actually increase the fibrosis over that area. Generally, we will use this if we think there's a clean case, there's no injury to the esophagus or the stomach, because there is a risk of infection if we think that, if you have serosa tear and things like that, or it is a case where there may be compromise to the vasculature of the stomach, then we want to avoid the use of pressures, but in most cases, the use of pressures is actually quite safe. So usually I will usually do a slip knot to try to close these high tension areas, because I find that sometimes if you put even 2 or 3 knots, the suture tends to ends up being a loose knot. So usually I do a slip knot. But in this case, you can see that even with closing of the posterior crura, you can actually achieve quite high closure. What you want to really avoid is that what you want to look out for at the end of closure is that the esophagus is just really snug in the diaphragmatic defect, and it's not like pouting or anything. Because sometimes if it's pouting, then it suggests that your closure is too tight, and that might result in some dysphagia from the patient. Okay, so for fundoplication, there are several types, and this is a little bit similar to what we do for GERD. The 3 types of fundoplication: there's anterior, there's posterior, and there's also a total fundoplication. It's usually added to the repair. It restores the anti-reflux barrier. It should be tension-free, and for patients with normal motility, I think the golden standard is actually to do distance, even though we do worry that there will be more dysphagia if we do a distance fundoplication. Gastroplasty, I will have one paper to discuss the role of gastroplasty, even though we don't formally do it, as we mentioned. There is a tope fundoplication, which is a posterior 270-degree wrap, and then we can also do an anterior wrap, which is the DOS fundoplication, or we can do this. Sorry, this is a tope. This is once you tie the sutures, it actually becomes a distance because it wraps around the esophagus to fundoplication, what are the results of that 270 tope fundoplication versus total fundoplication? We do see that the early post-operative dysphagia is actually greater in the it's actually lesser in the tope group. So the tope group is actually much better in terms of dysphagia scoring for liquids as well as solids at 12 months, and actually both have quite good symptomatic as well as esophageal acid exposure after 12 months. If you compare the RCT, actually it shows that the dysphagia scores are actually quite similar in both the total as well as the posterior fundoplication. Even though in classical surgical dogma, classical surgical teaching, we do think that instance may result in greater dysphagia, even though the results of the good control may be much better. If you compare total versus partial fundoplication in the surgical repair of paraesophageal hernias, again, we see that the outcomes are there's improved swallowing in the tope group compared to the distance group. But I think that this is probably quite early. This is for early follow-ups in the first 1 year or so. But I think the literature do suggest that over time, the distance as well as the tope is fairly similar. So this is just a very quick demonstration of how we do tope fundoplication. So after we reduce the esophagus, we have to dissect the vernier sac, the excessive vernier sac. If not, it kind of like gets in the way of your fundoplication. So after that, we will have to bring the stomach anteriorly, do the Shushan to make sure that it's relatively tension-free. And usually at the first stage at the top, I will anchor it to the bra so that it's fixed. It's a little bit like a show plexi kind of a maneuver. Then following that, we will just place sutures at both sides. So again, this is on the left bruise. You want to just anchor it. And following that, we will place sutures along 3 or 4 sutures on each side to complete the tope fundoplication. So the use of mesh is really selective, it's not routine. In fact, I would argue that probably it should be used quite rarely. There is no proven long-term superiority when you use a mesh, and there is always a fear of erosion, mesh erosion into the esophagus if you use a mesh, even though we know from the surgical literature that mesh erosion, even though it's quite weird complication, is actually rather rare. So in the randomized control trials comparing the use of mesh with without mesh, we know that actually the recurrence of hiatal hernia is not higher in the non-mesh group, and in fact it's slightly higher in the mesh group, 9% in the mesh group versus 3% in the non-mesh group. And pretty much the use of PPIs, the post-operative esophageal acid exposure, quality of life, that's all quite similar whether you use a mesh or without mesh. And in very long, even in very long-term follow-up of 13 years where they do a CT scan of the upper abdomen after 12 or 13 years, we see that there's actually not much difference, and using a mesh does not reduce the chance of recurrence. What we do see is that the dysphagia scores may be slightly better in the suture alone group. So I think where possible, it's probably better to just use suture repair instead of using a mesh. Again, in this RCT that compared the use of sutures versus sutures reinforced with non-absorbable mesh, again the results are fairly similar. There's the results with the use of mesh is not really better, and so the similar number of surgical intervention and satisfaction scores are pretty much similar. Yeah, so again, very similar literature. When we have 3-way randomization into sutures or absorbable mesh or permanent mesh, there's again no difference in the rate of recurrence, but either like between the 3 groups. And between the 3 groups are fairly similar. But those with absorbable mesh did have more epigastric pain and regurgitation. regurgitation and dysphagia, even up to 5 years. So I think whenever you think that you need to use a mesh, then you should really reconsider, because number one, outcomes in terms of recurrences are really not much better. In fact, I would say it's quite comparable to not using a mesh. But even the use of our or absorbable meshes may sometimes give rise to more discomfort for the patient. So we should really consider the use of mesh quite carefully. This is quite an interesting case last year where patient came in with obstructed paracrural hernia. So you can actually see that this is the hiatal hernia defect, and next to the left cross there's actually a crural defect as well. So once we reduce that, the surgical principles are still the same. We repaired both the crural hernia as well as the diaphragmatic hiatal hernia with suture and pledgets. But because I was worried about the presence of two hernias, and in this case we use a mesh, and in this case we use a basic mesh, the BCST mesh. So remember, when you use the mesh around this area, one side needs to be coated as well. So the BCST mesh, which is a synthetic absorbable mesh, has one side that's coated, and we put it on the our side, and then we have to be quite careful with anchoring of the mesh. Some videos will say that you can use a tackle here, but I think we've got there are also some case reports of complications with the use of tacklers in this area. So we usually like to take bites. And in this case, we did a dorsal fundoplication. So you can see that the fundus actually quite floppy and can come up quite easily. And when we do a dorsal fundoplication, usually the first step is really to try to reapproximate and reconstruct the angle of peace. So we take the fundus to the esophagus on the medial stitch, and then we can quite easily do a very floppy dors for fundoplication. So we break the right around this case. So anterior gastroplasty has been shown to help as well after hiatal hernia repair. So what they do is they usually, with the use of suture passer, you can actually anchor the vesicle of the stomach to the anterior-abdominal wall. But we don't have much experience with this technique. But the RCT does show that it significantly reduces recurrence rates at least at 1 year. So it's something to consider if if you want to keep operating time short. If this is an elderly, very frail patient. So after you reduce the hiatal hernia, then maybe just consider doing a gastroplasty for the patient. So when you see patients and you counsel them for surgery, it's important to let them know that after hiatal hernia repair, they usually have some dysphagia, they may suffer from gastric float syndrome. Radiological recurrence, we know that is actually quite high in the surgical literature, but a lot of them usually do not require surgery repair. Usually these are radiological recurrences, and patient satisfaction is actually quite high after surgery. So this is the conclusion from ChatGPT, is probably will sum up everything. So length is, you need to make sure that you have adequate abdominal esophageal length when you close the hiatal hernia to avoid tension. If you have the benefit of a manometry before, then you should try to tailor the rep in terms of whether you think it's a distance or whether you think it's a dose or to fundoplication. Mesh is not really recommended unless in certain special situations. And of course, with surgery and any other operations, high volume surgeon advantage, where you have a high volume surgeon usually tend to affect outcomes. So that's the end of my talk. Thank you very much.
Thank you very much. We can open like a few minutes of question and answer. Any questions about previous lectures for this morning? Then we'll go into lunch. Questions? Oh, we have two.
I stop sharing.
Okay. Oh, we have some question from Zoom. Any question from your side? Julian did a wonderful lecture. Thank you. I think this was last question. Right? Oh, David, what's your favorite?
Prof, we have two questions.
Yes.
Thank you. I will ask about the Thank you. My name is Megan from Indonesia. I will ask about do you routinely perform endoscopic for check the door or tupe or this stitch? It's not you don't have to check with endoscopic. Yeah, intraoperatively.
Can you speak through the mic because we pick up the audio? Yeah. Speak through the mic.
So I don't think we usually have to routinely check. As in, are you worried about? It depends on what you worry about. Sometimes if the hiatal dissection is quite stark, so that you want to make sure there's no esophageal injury, then we may do a scope to assess the other procedure, make sure there's no esophageal injury. Of course, you can argue that sometimes if you do choroblasty and you do a tope, you want to make sure that it's not too tight.
Yeah.
But generally, when we do Nissens, we also want to avoid making the wrap too tight. It just needs to be snug. It's really a functional flap rather than a stenosis that you're trying to create.
You know that shoe shine movement?
Yeah.
And then you have a space below.
Yeah, like
Some people at the beginning, you can also use a bougie, 40.
Yeah.
Or you can do a scope after. If you feel that the wrap is too tight or the chloroplast is too tight, you can do an scope. Or you can use a bougie, 40 French. To be safe. Some people they use it.
From the your lecture that you said that after 6 weeks there's no difference in swallowing either solid or liquid food. So if the patient come to the clinic and say that I still have some like stuck in the esophagus, we can still watchful waiting until 6 weeks or any other scheme.
So generally, I manage their expectations. I tell them for the first 6 weeks or 3 months, they may be some feeling of obstruction, and they have to eat slowly, take small meals. Of course, if they have total dysphagia, then it's something that you have to investigate much earlier on. But usually, I'll give it about 2 months for symptoms to settle down before I try to reevaluate either barium or gastroscopy if I'm worried that there may be stenosis.
This patient that will lose is an open door. So usually when they eat, the trans is very fast. So even though the motility is normal, as you close it, they will have this feeling. Of course, plus there's edema of the surgery. So for the week. So the situation is going to be feel the shock for the next at least 1 month, 2 months. Sometimes we do gastric empty study, we do scope, everything is normal. The most is also psychological.
Okay, thank you, bro.
Because they feel right.
Any more questions?
There are 2 questions online.
Yes. One question is, in subtotal cholecystectomy penetrating type, any tips on how to close the cystic duct?
Sujit can reply.
First question. Subtotal cholecystectomy penetrating type, any tips on how to close the cystic duct?
Sujit not on the microphone because online.
Okay, so you can use I use Vlog 3 and then put a string around it. The fenestration, this is subtotal, is considered. Actually, we don't do subtotal anymore. When Jiahao mentioned, he told you can actually go down to the cystic duct opening, and then when you close it, it becomes a total. So subtotal, only keep it as your last resort. Because if you're in doubt, so usually the issue is you have a stone stuck in the neck of the gallbladder, and that gives rise to fibrosis. So just cut on the stone. It's the safest to do. Just cut on the stone, and then you retrieve the stone. Then you can see the opening. If you can't see bile coming out, press on the bile duct, okay, and then see if there's any bile coming out. Okay, and then you see if it's a type 1 Mirizi or if it's a type 2 Mirizi, you can actually use the flap of the gallbladder to close the defect. Type 3 and 4, you will need the epidural stone. But do you know the stone? See from inside, then you can just use a Vlog trio, or if you don't have Vlog trio, micro trio, just do a first string and then like this. Put a drain if you're in doubt. That's all. One more question.
Thank you. Just one more question. Should intraoperative finding show inflammatory mass in the right lower quadrant? Would you put a drain or perform
Let's make who's going to put a drain and end up. So, how many of you? Who will do a right hemicolectomy? Because the only choice is to do a hemicolectomy because it's a diverticular disease, right? In Asian patients, mostly it's the right side. Who will do a hemicolectomy? Oh, okay. The answer, I think, right?
Answer is don't get that. so don't try to face this situation. Okay, mass needs to be identified clinically. Don't use your hand, then forget it. You cannot be surgeon, right? So if you feel a mass, then there's something not right. Okay, and you don't go and dig out all the mass. And if you go and operate on the mass, be prepared to do it right. So first thing is try not to get into this situation. If you feel a mass, then the options are different. Do a CT scan, see if there's any conservative treatment possible. Maybe consider drainage, even before going in. Okay. And then subsequently, you can check if this is still feasible to do. Is this a cancer? So do a colonoscopy. The mass and inflammation settles down. So first step is try and avoid this situation.
Okay, great. So the time is short. Let's have a photo group together, then a quick lunch, and then we will be back. The MCQ we will move to tomorrow because our SIP lecture is tomorrow. I'm sure it will be okay. Okay.
Let's proceed outside, right outside the door first for photo, then we'll proceed to lunch after. Tanong ako.